Good morning.
Good morning.
At this time, please begin the live stream of this meeting. Good morning. My name is Dr. Raquel Ingram, and I am the presiding officer for today's regular meeting of the North Carolina Board of Nursing's Education and Practice Committee. The Education and Practice Committee meeting of the North Carolina Board of Nursing will now convene. We have a quorum for the meeting. This is an official meeting of the Board of Nursing conducted in accordance with North Carolina's Open Meetings Law under Article 33C, Chapter 143 of the North Carolina General Statutes. The board recognizes the public's right to attend and observe this meeting. As such, this meeting is being streamed on the board's YouTube channel. I'd like to remind everyone to please turn off all electronics or place them on mute for this meeting. Board members will be using an electronic device to view documents for this meeting. All documents for this meeting are located in the onboard application in the meeting book or resources section. In the event of an emergency, when an alarm is sounded or instructions for evacuation are given, everyone shall immediately exit the building at the nearest exits. Once you are outside the building, a staff member will provide appropriate instructions. The board's mission, vision, and values. They drive our work as a board and serve as a reminder to us as we carry out our business. The mission of the board is to protect the public by regulating the practice of nursing. Our vision is leading nursing regulation through exemplary nursing care for the public. In pursuit of our mission and vision, we focus on three core values. The first is equity. We adhere to the principles of fairness and consistency in regulation. Next is integrity. We act in good faith in protecting the public, and agility. We champion innovative ideas and adapt to emerging healthcare needs. In accordance with the State Ethics Act and the Code of Conduct for members of the North Carolina Board of Nursing, it is the duty of every member to avoid both conflicts of interest and appearances of conflict. Does any member have any known conflict of interest or appearance of conflict with respect to any matters coming before the committee today? If so, please identify the conflict or appearance of conflict and refrain from any undue participation. We'll be able to hear your comments and questions. Are there any additions, modifications, or reordering of the agenda requested at this time? Seeing none, do I have a motion regarding adoption of the agenda? Dr. Shaw has moved to adopt the agenda. Do I have a second? Dr. Kistler has seconded the motion. I will now call for a vote. All in favor by show of hands, and the vote is unanimous, or it carries. Thank you. Are there any modifications of the March 4th, 2026 meeting minutes requested at this time? All right. Seeing none, do I have a motion regarding approval of the meeting minutes? Thank you. Dr. Steele has moved to adopt the meeting minutes. Do I have a second? Okay, Kelly Dahl has seconded the motion. I will now call for a vote. All in favor by show of hands, and the motion carries. We are now at agenda item 3, which is the open comment period, the portion of our agenda. The purpose of the open comment period is to provide members of the public with an opportunity to share their concerns, offer views, and present questions regarding issues that impact nursing and nursing regulation. Ms. Hampton, has anyone signed up for the open comment period at this time? Thank you. At this time, we have no requests to speak during the open comment period. Therefore, we will move to the next agenda item. The next agenda item is opening comments, setting the foundation, the purpose of the Education and Practice Committee, which is agenda item number 4. The purpose of the Education and Practice Committee is to support the work of the board to review matters related to education and practice and to make recommendations to the full board as charged. In May of 2026, the board charged the Education and Practice Committee to review current laws and rules applicable to the nurses' use of artificial intelligence, or AI, gather an understanding how AI is being used in various settings, and draft a position statement on the use of artificial intelligence in nursing practice. Multiple board staff departments have been involved in researching and gathering information and data to be presented at today's meeting on the role of AI in nursing practice. The goal is to provide a comprehensive overview of AI in nursing practice and determine what role or guidance the board is able to provide within our statutory authority. Along with this information, board staff have also invited external speakers from healthcare systems and nursing programs to present on this topic. I'd like to take this moment to thank the speakers for attending today's meeting and sharing their expertise on AI in nursing specific areas per their area of interest in healthcare or their area of expertise. The information they provide will assist in the committee's discussion of this matter throughout the meeting. After each presentation, there will be an opportunity to ask the presenters questions to clarify the information provided. Each of these presentations will contribute to the committee's understanding of the use of AI in nursing practice and regulation of AI. Board staff has drafted a position statement for our review based on the information obtained during preparation for this meeting. I will now ask Deputy Executive Officer, Dr. Sarah Griffith, to provide opening comments entitled Setting the Foundation, in which she will share the results of the AI-related survey. Dr. Griffith.
Thank you, Madam Chair. I'd also like to welcome all staff and guests and anybody that's watching virtually. Thank you for attending this meeting today to learn about AI in nursing and our role as the Board of Nursing in providing guidance to nurses across the state of North Carolina. As you listen to the information that's presented today, keep in mind that the board is not attempting to regulate artificial intelligence or AI, dictate or advise on the preferred AI platforms that healthcare agencies or educators may use, regulate how agencies utilize AI or choose not to utilize AI, or state whether AI in nursing is a good thing or a bad thing. As a regulatory agency, we are aware that AI is being used in healthcare agencies, and it is our duty to provide a resource to nurses to guide their practice if there is a decision to utilize AI. The scope of this charge is how nursing practice intersects with AI and guidance for nurses on their legal responsibilities as they relate to the Nursing Practice Act and the North Carolina Administrative Code. Today's roadmap is to set the foundation for meeting with this goal of producing a position statement for licensed nurses in North Carolina. We will start with an analysis of the survey sent to all nurses via the email address on record with the board, and then we will shift to understanding AI in relation to practice, education, investigations, and then legal. This section will provide presentations from practice and education stakeholders as well. Then an overview of the national organization position statements and existing occupational licensing board position statements will be reviewed. The meeting will conclude with a presentation of a proposed position statement for the committee to consider. Now let's jump into the results of our survey. The survey was titled North Carolina Use of Artificial Intelligence in Nursing Practice, was created in collaboration with a team of board staff members seated around the table today. The 10-question survey was designed to not be overburdensome to licensed nurses, but there were questions that we felt we needed answers to in order to facilitate the conversation today. The survey was emailed to all licensed nurses on June 24th of 2026 and was available until July 12th, 2026 at midnight. We were pleasantly surprised to see the responses increase to over 3,000 in a 3-week period. At the conclusion of the survey, there were 3,568 responses. Based on the number of responses, it could be assumed that artificial intelligence as it relates to nursing practice is very important to licensed nurses in North Carolina. So question 1 is, what nursing license do you hold in North Carolina? So we wanted to understand who the nurses were that were responding to this. And overwhelmingly, 78% or 2,795 respondents were registered nurses. 16% were licensed practical nurses, and then 13% of the respondents were from the APRN group: nurse practitioner, certified nurse midwife, certified registered nurse anesthetist, and clinical nurse specialist roles. Question 2 was, how many years have you practiced as a nurse? 57% of the respondents have been licensed for 20 or more years. And then the other age brackets were evenly distributed between 9 and 12% of the responses. In question 3, what is your primary practice setting? 32% or 1,157 respondents reported their primary setting as hospital or acute care. 20% or 696 respondents in ambulatory care or outpatient care. 15% or 523 respondents were in the other setting, and 6% responded from an education setting. In question 4, do you currently use AI-enabled tools in your practice setting identified in question 3? In this question, we did add branching logic. So if a respondent selected A or B, they would go to question number 5. If the respondent selected C, D, or E, the respondent would go to our very last question, question 10. So in this response, 34% of the respondents reported that there are no available tools in their practice setting. 35% or 1,252 respondents reported they either use regularly or occasional use of AI-enabled tools. In question 5, you indicated you currently use AI-enabled tools. How are you using AI tools? Our goal with this question was to understand the types of tools nurses were using within their practice setting. This question allowed for multiple responses by the nurses. Most nurses responded to this question indicating using some form of documentation or charting assistance. Evenly selected were clinical decision support, administrative or workflow tasks, patient education or communication, and education training for staff or students. So nurses are interacting with AI tools in their employment settings. In question 6, how often do you use AI-enabled tools in your practice? Of the 1,252 responses, about 50% reported using AI tools daily. Almost 400 indicated using them on a weekly basis. In question 7, what benefits have you experienced or anticipated from AI use? And this was a select all that apply question. The top 3 benefits reported were improved efficiency or time saving, 891 respondents, reduced documentation burden, 609, better access to information, 608, and then other individuals responded with other access information. In question 8, how confident do you feel in your ability to use AI tools safely and appropriately in your practice setting? Of the 1,252 responses, about 78% or 978 respondents indicated they felt very or somewhat confident in their use of AI tools in their practice setting. In question 9, have you received any training on the safe and appropriate use of AI tools in nursing practice? And this was evenly split. 47% indicated they had not received any AI training, with 46 indicating that they had received some training, and 7% were unsure if they had received that training or not. In question 10, what we looked to accomplish here was for nurses to share any additional comments related to AI in general, AI in their practice setting, so that we can get a better understanding of what nurses think about AI. So included in this slide is an AI-generated word cloud of the keywords used by nurses in the open-ended survey. Some of the keywords that we would like to focus on are patient safety, training, accountability, clinical judgment, critical thinking, and privacy. I'm sure there's many of these keywords will be referenced throughout our presentations today and during our discussion of the position statements. Survey responses revealed mixed perspectives on the use of artificial intelligence in nursing, with most nurses supporting it as a supplemental tool rather than a replacement for clinical judgment, critical thinking, or patient-centered care. The primary concerns focused on accuracy, reliability, privacy, security, and the need for clear policies, oversight, and accountability when AI is used in a healthcare setting. Nurses also emphasize the importance of education and training to ensure appropriate evaluation of AI-generated information and understanding its limitations. While many nurses identified benefits such as improved documentation, workflow efficiency, and access to information, they consistently stress that empathy, professional judgment, and human connection remain essential elements of nursing practice. So some of the key themes from the open-ended survey respondents expressed optimism about the role of AI in healthcare, emphasizing that it should enhance, not replace clinical judgment, critical thinking, and meaningful human interaction. Key concerns centered around the accuracy of AI-generated information, potential hallucinations, and the need to protect patient confidentiality through strong oversight, policies, and governance. Participants also identified documentation support as valuable use case and highlighted the importance of ongoing education and training to ensure AI tools are used safely, effectively, and responsibly. So in the reference section of the onboard application, there is a PDF with all the comments provided by the respondents. On slides 15 through 18 of this PowerPoint presentation, I will highlight some of the comments that we received. There have been no edits to these comments, except I bolded some of the key words in some of these comments. So based on the survey, there appears to be some apprehension of AI tools taking the place of nurses, as seen in comment number 14. But in comment 21, the respondent indicated that AI could be helpful in saving time for nurses. In comment 32, the respondent outlines the nurse's responsibility and accountability and also feels that AI could help, but there's also risks of utilizing AI. In comment 48, the respondent indicated that education was needed on the nurse's use of AI. In comment 63, the respondent cautions nurses that outputs could be wrong, so verifications were needed. In comment 111, the respondent discusses education's use of AI and concerns with becoming overly reliant on AI. They may not fully develop the critical thinking, clinical judgment, and decision-making skills that are essential for safe and effective patient care. Each of the comments on this slide, number 130, 153, and 217, indicate some of the benefits of utilization of AI in nursing practice and the delivery of safe care while understanding the limitations of AI. The respondents indicated that healthcare agencies need to develop clear policies and clear guidelines on the use of AI. This last slide is a compilation of comments from an education and practice perspective. As you can see, survey respondents generally view AI as valuable and increasingly necessary support tool in nursing practice, but strongly believe it should supplement, but not replace, again, that key word, clinical judgment. Key concerns center around the need for education, safeguards, and clear legal and scope of practice guidelines to ensure AI is used safely, ethically, and appropriately across all nursing roles. Respondents also expressed apprehension about the potential negative impacts on bedside care, documentation responsibilities, patient outcomes, and workforce dynamics if AI implementation is not carefully managed. Madam Chair, that concludes the overview of the survey.
Thank you, Dr. Griffith. Are there any questions related to the survey results? Yes,
Questions. Oh, sorry. No. Thank you. No questions. Well, yes, a question, but it's more of an observation. So did you notice that 2 of the responses used AI to make the responses? Okay. All right.
All right. Are there other questions? All right. Well, thank you, Dr. Griffith, for providing us with this wealth of information. I am impressed with the number of respondents to the survey. That's a great thing in that small time frame when we know when we do research, when we send out surveys for anything, we can give them 3 months and we might get 25% of that. So that was really good. And so we will continue. Okay, so we will move to agenda item 6. And so I will now turn the meeting over to our Director of APRN in Practice, Dr. Kimberly Lusano. Did I get it? And then Practice Consultant, Mrs. Stacy Thompson, and Nursing Regulation Consultant, Dr. Jenna Caparel, for their presentation on the role of AI in practice. Thank you.
Thank you, Madam Chair. So, what are the AI implications in clinical practice? That's what we set out to try to help summarize as current. Obviously, this is evolving very fast and furiously. So, I think AI can enhance clinical decision-making, improve documentation efficiency, and support patient care. Successful implementation depends on clinical understanding, trust, workflow integration, transparency, and organizational and institutional policy or governance. AI functions best as a clinical support tool and not an autonomous decision maker. I think that's a key thread to the theme here. So, healthcare professionals often question how AI systems generate recommendations, creating concerns about trust, reliability, and accountability. All clinicians of every level of licensure and interdisciplinary team collaboration are more likely to use AI when recommendations are explainable, actionable, and clearly improve patient care. So clinical rationales, evidence-based support. When AI outputs conflict with clinical judgment, nurses should continue to rely on professional expertise and maintain responsibility for final decisions. AI scribes show promise in reducing documentation burden and improving workflow efficiency, allowing more time with patients potentially, and also other tasks and responsibilities. So I think AI-generated documentation will and always consistently require human review and editing, and reinforcing the need for ongoing clinician oversight and accountability. You will hear in the literature and you will seek AI collaboration. That is that human review and quality control check. So as the research evolves, something to know as we were reading through some of the literature, you see collaboration, and traditionally collaboration was amongst the interdisciplinary teams, and now we're seeing this collaboration with the AI tool that you're using. So, consistent concerns are potential bias and equity. AI systems may perform differently across patient populations, languages, accents, cultures, and underrepresented groups, potentially contributing to health and resource disparities. Continuous monitoring and evaluation are therefore essential for the nurse to ensure equitable care. As you will see in the following literature review, predictive AI clinical decision support systems demonstrate performance that can be variable across specialties, settings, and populations. More information is needed for the real-world implementation. There's a lot of retrospective information out there, but as everyone understands, there's a lot of evolution very, very fast in using these systems. So it'll be interesting to see what comes down the pipe. As the evidence evolves regarding the safety, effectiveness, and implementation of AI in clinical practice, adherence to evidence-based practice is essential to ensure the decisions remain grounded in the best available research, clinical expertise, and patient-centered outcomes. In summary, nursing practice is already incorporating AI competencies, which include practice standards like informed consent, privacy protections, transparency, documentation standards, bias mitigation, and professional accountability. AI may augment nursing and advanced practice clinical judgment, not replace it, while governance frameworks ensure patient safety and ethical use. So with that, I'm going to send it to Stacy Thompson for the literature review.
Thank you, Dr. Lasana. Good morning, everyone. A review of the literature regarding the use of artificial intelligence in nursing practice was completed using the AHEC Digital Library as a search strategy, which utilizes various databases to identify relevant articles. Board staff also submitted relevant articles for inclusion in the review. Literature on the topic from 2023 to 2026 yielded a substantial number of articles to be considered. Inclusion criteria refined the yielded results and included full text, scholarly and peer-reviewed, and open access articles. A separate search was conducted specifically in the Journal of Nursing Regulation through the National Council of State Boards of Nursing, and a total of 13 articles were selected and presented in the literature review to represent AI use in practice by RNs, LPNs, and advanced practice registered nurses. All of the articles that were reviewed are available in the resources section of Onboard. Information around documented uses, benefits, and challenges is presented to summarize the review of the literature. Documented uses of AI in the literature are shown on this slide. Voice assistants, and examples of that are voice charting, retrieving patient data hands-free, answering clinical queries, dictating clinical notes, chatbots that are used to triage clinic calls or for scheduling, predictive algorithms that forecast clinical risks, anticipate patient deterioration, and prevent adverse events like falls risk, sepsis, pressure injuries, readmission, length of stay, robotics that are used to deliver supplies and specimens, ambient scribes that listen to conversations and auto draft electronic health record entries and flow sheets. And these tools are able to auto map relevant updates and care details directly into the flow sheet structures. Monitoring tools such as smart sensor tracking, automated vital sign analysis, fall risk prevention, and predicting patient needs. These tools analyze the EHR and vital signs to anticipate risk before they become emergencies, also to detect deterioration alerts, risk scoring, and discharge planning. Benefits of using AI in nursing are cited in the literature, and you'll see a lot of repetition as we go through the literature. You'll see the links to the survey results as well. But the benefits cited include facilitate problem solving, timely data interpretation, workflow enhancement, and early disease detection. Challenges are also cited and include the fear of loss of human connection, the accuracy of the data, unintended consequences such as the hallucinations, and the professional accountability that's already been mentioned. Also, ethical challenges are cited and include an unintended bias. There may be skewed data that misrepresents a diverse population. The liability. So what happens when AI recommends something that contradicts the standard or contradicts the agency's policy, and also privacy and security. Research consistently supports several key points. Number one, AI is a tool and does not replace clinical judgment. Second, agencies should develop policies and education for roles that use AI in their daily work. Third, more studies are needed to evaluate AI's impact on patient outcomes. And fourth, nurses should participate in evaluating AI tools to align with the legal and ethical standards. One interesting framework was cited by U 2025 and is shown on this slide. It uses the acronym NURSES, which I found pretty interesting. The author suggests nurses must apply critical thinking to decide when to adopt AI to improve patient outcomes and when to avoid it to prevent potential harm. So the nurses framework guides nurses to navigate the AI basics, to utilize it strategically, to recognize its pitfalls, develop skills through the education, understand the ethics, and then shape the future. Nursing leadership and educational institutions are encouraged to formally adopt such AI literacy frameworks to ensure that the clinical translation of AI is safe, effective, and absolutely patient-centered. This concludes the literature review of artificial intelligence in nursing practice. I'm going to hand it over to Jenna, Dr. Jenna Caparel, who will introduce our guest speakers.
All right. Thank you, Stacy. So I will introduce our first guest speaker this morning, Dr. Kay Lytle. Dr. Lytle serves as the Chief Nursing Information Officer for Duke University Health System. She leads initiatives focused on healthcare technology, digital transformation, and the responsible implementation of artificial intelligence to improve patient care and nursing practice. Dr. Lytle received her Doctor of Nursing Practice degree from Duke University School of Nursing, where she currently serves as adjunct faculty in the Health Informatics program. As a member of Duke Health's algorithm-based clinical decision support oversight committee, she helps guide safe, effective, and equitable use of clinical algorithms and AI-enabled technologies across the health system. Welcome, Dr. Lytle.
Good morning, and thank you so much for the opportunity to speak with you today about our use of AI for nursing at Duke Health. I wanted to start just a little bit about kind of our path to responsible AI for nursing. We are looking at these three approaches. So we are using solutions we buy. We are using things provided by our EHR vendor. We also buy other third-party solutions to support us in practice. We are fortunate in being a large academic. We have an in-house team to help us build tools called our Duke Institute for Health Innovation. And so we have built internal models that we validate and deploy. And then we're also partnering with specific vendors to co-develop solutions together. So we're using all three of those, and you'll see some of those examples as we go forward. I wanted to point out at the bottom of the slide, the human in the loop. So keeping the nurse in the loop. We are not looking at replacing the nurses. That question comes up a lot. That is not on our radar at this point. And most importantly, nurse-driven. So we're engaging nurses in the process throughout, from the beginning to the end. And that's very important for us, that they are there about decision-making, workflow, how to use it in practice, what are the outcomes. So I'm going to go through some of the solutions that we're using. This first one, our Sepsis Watch tool, was one created by that DHI group. We were having trouble with sepsis. We've been using this tool since at least 2018, maybe a little bit earlier than that. The tool that we had was not performing. We went with a deep learning model that was developed. It uses 60 different variables. So that's the kind of the deep learning approach there. The other piece that we did was we changed, instead of every bedside nurse responding, our rapid response team came, responded to the alerts, assessed the patient, and intervened with the provider to get the patient the orders and the care that they needed. And we found that very effective. You can see the improvement we had in our deaths attributed to sepsis as a result. One of our EHR examples is called augmented response technology, or we actually call it iBART for in-basket. In-basket is where the patient reaches out to the provider with questions of symptoms or side effects from medication, treatment, any kinds of questions that they put forward. This is provider-facing, so that could be nurse practitioners, for example, as well as nurse-facing. We have patient engagement centers where the nurse is the one to respond and tee up the answer for the provider. The responses have been deemed more empathetic by our patients, and it saves nurses about 30 seconds per patient message. And I should add, they're viewed as more empathetic by the patient. Often when we tell them we use AI, which is our approach, they then change their mind. Some of the patients don't actually like thinking that AI helped generate the response, but On the inpatient side, we're just piloting this two-way audio-video solution with computer vision with a vendor. We have two components, the virtual nursing. It has an AI model for pressure injury prevention, and then that's in the learning phase. We're not quite using that yet. And then it has ambient AI to engage an interpreter. So I'm going to say, ask for a Spanish interpreter that comes in the room over the TV, which has been actually fabulous. And then the other is remote safety observation, which is our virtual sitter program. And that has a model to help with falls. We just finished our clinical validation and are waiting on sign off to go live with that. This is a little more detail on the pressure injury side. The virtual nurse sees a dashboard with timers for when patients are due for turn so they can intervene and identify the care nurse or the nursing assistant who could come and make sure we stay on time with that standard of care and then what positions people have been in. And then on the right is a little bit more of the detail around the fall risk. They identify medium risk as the patient's shoulders are off of the back of the bed or the chair. Their feet may or may not be on the ground, so it's that kind of sitting up. Are they getting ready to leave? It's meant to draw the attention of the observer to the screen and look more closely to say, do they need to intervene? You know, today they're just on their own without any support to look at who's getting up. So we're hopeful that this will really draw attention for them. And then the red is people are standing up. And then we have a standard escalation process that we use. That part of it really doesn't change at all. Something a little bit different, we're doing an AI supply solution in one of our units. And you can see across the top, there's little cameras that are above the supply carts. There's also some that aren't really visible in the picture under the shelves looking down on the supplies. And so it will report that it's 50% stock or less, or 51 to 75, greater than 75. It will get them to replace the supplies. It will send notices we need more supplies to our supply vendors. And coming soon, we're going to have an ambient component where the nurse can go in the room and say, where are the TED hose? And it'll tell you the second card on the right, the third shelf. And that's important. I might not be something I use very often, or I might be floated to that unit, right, and not know where things are. So people are very excited about that coming. Ambient documentation has already been mentioned today. Our providers, so including our nurse practitioners, use ambient documentation to write notes with the patient where they then edit and save to the record. That has been a huge success, reducing people's burden of documentation after hours at night, particularly in the ambulatory space. We're now using it in the emergency department as well as inpatient as well. Nursing is a little bit of a different story, and it's still very new technology. A lot of it is not generally available from the vendors. We did development work with the vendor and piloted for almost a year. We have paused that work and are getting ready now in about 2 weeks to kick off another pilot with the vendor that our providers are using to provide their solution. But I think the notion of the structured documentation to the specific discrete rows and getting that right is very different than the general writing a note that the providers face. So it's definitely been more challenging. Most of the vendors are only working in the med-surg space, adult med-surg, not ICU, not any of the specialties, ED, any of the other environments at this point. So. Another DHI tool that has just been generally released to our providers is Scout. It's a EHR search and synthesis tool. So you can query, like, give me a summary about a patient. Maybe it's a patient you haven't cared for before. We're very excited about this. It looks like nurses are going to get access to this in October when we do our EHR upgrade. And we have training and process around that to come out. One of the interesting things is it provides evidence cards, and it has a little link, like a footnote, if you would, about all the information it provides. And then you can open up the evidence. So in this example, the screen on the right, it opened the history, admission history and physical, and exactly the piece of information that it drew into the summary that it provided for you. We are doing work now to develop a handoff tool for med-surg. Using this, we're hoping to reduce the handoff time by about 50% and help prepare charge nurses as well as prepare the nurses for multidisciplinary rounds, trying to reduce some of the line use that we have. So a lot of work in that space. Coming this fall, we're doing two pilots, one with robots. Meds to Beds is our outpatient pharmacy discharge prescription. It won't go to the patient's bedside. It's going to go to the nurse station for the nurse to deliver to the patient. After hours, it'll do some of the pharmacy and supply chain activity. And then on the right is the controlled substance wasting solution. That is, so I don't need a second person. It has a 360 camera. It uses some AI. You then video watch the waste. The AI can flag things you need to pay attention to. And it does random sampling. So then I can put it in. The pharmacy will have a chain of custody. We'll then do testing. So we're hopeful that this will also help us with our diversion program. And then I mentioned we have this algorithm-based clinical decision support oversight committee, or ABCDS. We use this process regardless of whether we develop solutions or if we have vended solutions. Sometimes vendors get FDA approval on their solution, where the software is considered a medical device or the AI is considered a medical device. Sometimes they do not. It's not in the FDA purview. And then we kind of do our own. Is what we're developing require FDA approval or not? How do we validate it? How do we ensure it's effective, accurate, safe, fairness, all of those kinds of things? And we have a checkpoint process to get through to the point that we start using it in clinical practice. So I mentioned the AI validation we had done on the vendor falls solution. So we're waiting on sign off to do the real world impact demonstration on that process. And part of what we had to do was prepare all of the training and say how we were going to train staff. So that is a component of that. And I did want to mention, we did come out a couple of years ago with some clinical use guidelines for generative AI. So when ChatGPT came out, how do we prepare people for that? And what are people's responsibility to review it, verify it, be accountable? If I'm making a decision based on that, then that's my responsibility. Obviously I need to be clinically trained to be able to validate the output. How we not put PHI in the publicly available tools. And we have a list of, tools I can put maybe business sensitive information in, things I can put PHI in that's smaller, and then, what I can't do. And I know specifically you all asked about training. I just wanted to say that training I mentioned as part of the ABCDS process, it is specific to each one of those tools, right? What people need to know, how they're going to use it in their workflow, what things they need to be looking out for. And the validation we did with the Falls tool really guided us in what we need to train our observers, because our observers are not licensed people. They're not even necessarily nursing assistants. So how are we training those people, and what is it they need to know for the alerts that they're going to see? So with that, I just again reiterate, I think having nurses engaged in the process is very important, and I am open to any questions you may have.
Thank you so much, Dr. Lytle, for your presentation. I love the concept responsible AI. That's really nice. Questions for Dr. Lytle? Dr. Shaw.
Thank you for, sorry, I got an awkward turn here. Let's see. Thank you for the presentation. I have a question. I see a lot of healthcare systems have lots of tools around AI platform usage and such. So have you, as a leader in AI and informatics in your healthcare system, have you all done an internal engagement with your engagement survey or anything around engagement or surveying your nurses within your healthcare system around AI and what their sentiments are compared to all of the tools that we have or you might have within your healthcare system?
Yes, we've done some things in collaboration with the School of Nursing to survey staff and then broader. We also brought forward some, like a AI educational session, a half day, bringing people to the table. And we've been using staff advisory councils that are project-based. Like, so for the handoff tool, we're getting ready to stand up the advisory council with people across the health system, not just the units that we're going to pilot, because we want to design it with everyone in mind and what the workflows are going to need to be and the concerns that people have and how we help educate people and address the concerns they bring to the table about, wanting to be in the loop and wanting that human touch, and where are we adding benefit and where do they think it's not. The in-room computer vision solution, you all mentioned privacy earlier, has raised a lot of conversations with the staff about that. And I think that's absolutely key, is to have them engage and get their feedback. And not just point in time, but ongoing as we're using the solutions and issues are coming up. We have huddles daily, weekly on different parts of the project. So, yeah.
Thank you. And from a healthcare system perspective, have you received any feedback around the environmental sustainability around AI? And I know in the public, we talk about protecting the public. There are some implications to AI, the use of consuming more energy, more water. Those
Yes.
things are out in the community, in the public, and that will be perhaps kind of a side effect of AI. I know we're not pushing it, it's here, but
Right.
we're talking about it, and it will generate, environmental concern. So is that something that your nurses have brought up as users of
That's
AI?
not something I have heard. I have heard
Mhm.
about that, and I think it fits well with um, Duke, both on the university and the School of Nursing side in particular, have that environmental sustainability approach. And that's also part of the curriculum. And I do think that's something we have to address as a nation, I guess would say, much less the world, of how are we going to deal with that and how do we approach it? Yeah. Thank you for that question.
Thank you, Dr. Shaw. Any additional questions from board members?
I have some, but they're for the committee, not necessarily.
Okay, all righty. Thank you, Dr. Steele. If not, I will now, board staff have questions. Thank you.
Dr. Ingram, if I can raise a question. Thank you. Dr. Lytle, I'm Meredith Parrish, Chief Legal Officer for the Board of Nursing. Thank you so much for this informative presentation. I just have a few questions for you. Since the use of AI is relatively new, right, and technology develops so fast, is there a reason why the School of Nursing and Duke chose to develop their own internal AI system, if you know?
Many of the choices are usually there aren't solutions available. Like, take Sepsis Watch, that was something at the time that really wasn't available. And often we will shift over time where we develop something and then maybe over time the EHR vendor does, or we purchase a third-party solution and then our EHR vendor does. Then a lot of times we will convert back to using that tool. So it is a fluid process. Yeah.
I think it just from a perspective, from a legal perspective, I imagine that you offer good insight as to what you need from a regulation standpoint.
That whole committee that I sit on has a regulatory group with compliance and legal people that sit on it and do the review and go look at, is this something, if we're developing a tool like a Sepsis Watch, and how does it, do we need FDA approval? Where are we in that clinical decision-making process? Where is it automated? I think for like radiology practice, which is very different than nursing practice, where it's reading images, right? There's all of those considerations. It's actually quite fascinating, but yeah.
I see that as really beneficial and probably built into why your patients don't realize that it's AI generated
Yeah.
initially.
Yeah.
My second questions kind of relate to the documentation. Documentation is so critical to nursing, and it is something that we see a large variety of violations when it comes to the Nursing Practice Act. Um, do you know if it saves as a draft in terms of looking at the process overall? When it converts the voice to the notes, does it save as a draft for the nurses who are using this?
It does, but it's not in the record where anyone can see it. So the person who did it has to go back in and look at it. Some of the more recent developments they've done, you could see where they filed it into those flow sheet rows, like the example had pain and the pain score and the location and
Uh-huh.
et cetera. It has a link to the transcript, so you can go back and review that. And some of the most recent updates are for the individual item, say the pain score, the patient said it was 9, it will link specifically like to that sentence or that phrase that was said. So you don't have to necessarily, maybe you were in the room for 15 minutes or 30 minutes delivering care, doing an assessment, whatever, then you don't have to look through the whole thing. Yeah.
That is also a huge time saver, I
Yeah.
imagine.
Yeah.
So just looking forward, can you tell when the nurse reviews it? So you said it's not uploaded into the documentation of the EMR until,
Actually, it's loaded in the EMR
is.
because it's integrated with the EMR, but it's
Okay.
not saved. Like I couldn't see your draft documents and you could not see mine, right? Like, so it's not available to clinically act on until the nurse saves it in the record. And I believe they're there for 24 hours, but the expectation is that people are going to save it, you know, like we encourage documentation as much in real time as we can, or at least by the end of your shift, you're going to save it before you go.
And then my last question is more, from a practical perspective in terms of reviewing the documentation. Can you tell, or you might not have had this opportunity to look back at it, but can you tell the length of time it takes for nurses to review this information? Is there a log, kind of like when you're going back and looking for whether a nurse has accessed PHI? Because my concern would be that a nurse goes in at the end of the shift and clicks yes. And so they're not really in the document long enough to create that assumption that you actually did a thorough review.
I want to say the answer is yes, because you would open the activity and then the audit log should be able to tell us how long you were there. We have from our EHR vendor what they call user action logs. And in the user action log, that's how we can get data. You might have heard in the literature, sometimes they'll report pajama time for providers, like how much time they're spending at night doing documentation. So we can get that. We can determine how much time people are spending in the chart, what activities in the chart, are they in the flow sheet, are they in the MAR, are they doing chart review? So I would say, yes, we should be able to get at that. Some of what we got presented in the pilot work we did were how many clicks we saved, how much time, how many documents they got filed. So we had some summary data around that. Yeah.
Sounds great. Thank you so much. I appreciate it.
Additional questions? If not, thank you so
Thank you.
much.
Thank
Again,
you for the
Dr. Leiter, for
opportunity.
your time and for sharing your perspective on AI in nursing. Thank you. And so, Dr. Steele, you mentioned you had questions. Okay.
Thank you. To the staff, I wanted to say great job on the research and the proposed policy and all of the things that you all were able to come up with. I just wanted to really register a few comments, not necessarily things that need to be done, but just things to consider for the future as we continue to develop the policy or the position statement. So number one, I think there's a literature review opportunity, specifically outside of nursing. I would consider stepping outside of the practice of nursing to other disciplines of noted topical areas like inaccuracy of information presented by artificial intelligence tools. So I loved what Duke presented in talking to my colleague, Dr. Shaw. She mentioned that other larger systems are also using very similar things, but then when we look at some of the survey results, some of the trepidation and some of the response was based on different types of AI tools, maybe not the robots or the cameras or other things, but maybe some of the words and diagnoses and the biased nature behind those. So I think it would be helpful to look into some literature on the inaccuracy of information, biases, race, gender, coding in general. And when I say coding, I mean being able to look at the Python coding behind some of the responses that are being used or that are being generated. For instance, I'm aware of a practical, hands-on AI tool use with ChatGPT. And so when asked the same question about a white person and a Black person, the Python code behind the response was completely different. And it used different factors to provide one answer about the white person and other factors to provide a different answer about the Black person. So I think there is a huge opportunity to understand what is the coding behind some of the responses before we continue to advise medical professionals to use or not use certain tools that provide diagnoses and responses to certain things. So obviously this is not on the same AI scale as robots and cameras and, you know, washing your hands, which is AI when it comes on automatically and things like that. This is on this is from the perspective of using words and, you know, generating ideas and generating diagnoses and generating commentary and feedback and things like that. So that's the perspective I'm speaking from. Then perhaps some literature on general use of AI and just technology in general, just general use. Prediction and predictive analysis, and then just unintended biases, because there are some things that AI just doesn't intend to do, but it does because it's searching human behavior over time and then using it to predict additional human behavior. So if human behavior over time has been historically disadvantaged, marginalized, and racist, then it could lead to additional practices in the same exact manner. And then perhaps we should relegate AI to just administrative tasks and other things that are, you know, like a camera or a robot taking meds to a nursing station, and other things that we were made aware of by Dr. Lytle and other larger systems. Almost done. Okay, I'm done. Thank you.
Thank you. Thank you so much, Dr. Steele, for that feedback. And so if we don't have any other questions at this time, did I see your hand? So this was question, so I didn't provide an opportunity to, for questions after Dr. Lusano and Ms. Thompson did their synopsis and overview. So this is that opportunity to, you know, ask them questions, and then Dr. Lytle, while we still have her here. Okay. Okay, all right. So at this time, we will take a break. We will resume at approximately 10:15. Thank you. The Education and Practice Committee meeting is now back in session. I will now turn it over to Dr. Caporal to introduce our next speaker.
All right, thank you, Madam Chair. I'd like to introduce Mr. Bennett Wall. Mr. Wall is the Director of Analytics and AI Engagement at ECU Health, where he leads the Health Systems Enterprise, AI, and Business Intelligence Strategy, Governance, and Adoption through cross-sectional communities of practice. In this role, he spearheads system-wide AI initiatives, helping to position ECU Health as a regional model for AI-enabled healthcare within an academic rural health system. Drawing on a career that spans population health analytics, service line leadership for women's and children's services, and healthcare operations, Mr. Wall has guided the implementation of enterprise-wide AI solutions and led the rollout of Microsoft 365 Copilot, empowering clinical and operational teams with advanced analytic capabilities. He also cultivates strategic partnerships with leading technology companies to deploy real-time AI-driven operational and patient experience analytics, developing predictive models that enable clinicians to address issues proactively and improve patient outcomes and satisfaction. Mr. Wall's expertise in public health and data analytics proved critical during ECU Health's COVID-19 response. As a key member of the Health Systems Pandemic Task Force, he leveraged geospatial intelligence and predictive modeling to monitor and forecast the virus's spread across eastern North Carolina, work that contributed to multiple peer-reviewed publications. Beyond ECU Health, Mr. Wall is active in industry collaboration and governance. He works with national healthcare organizations and serves on the North Carolina Healthcare Association Healthcare AI Task Force, contributing to best practices for the ethical and effective integration of AI in healthcare. He also holds community and professional advisory roles, including membership on Pitt Community College's Health IT Advisory Board and the Greater Greenville Chamber of Commerce, reflecting his commitment to health IT education, mentorship, and regional community leadership. Welcome, Mr. Wall.
Thank you so much. Wow, that sounds very fancy for just me. Again, my name is Bennett Wall, and this is an honor and a privilege really to be here. I've been at ECU Health for a little over 15 years. My undergrad is in forestry, so I didn't go to school for this stuff either. And I'll tell you, I started on this enterprise data and analytics team maybe about 15 or 16 years ago. I learned enough computer code to be dangerous to pull data out of Epic, our electronic health record. But I was very lucky to be picked up by a really amazing nurse leader, Kim Crickmore Osborne, and she needed access to data. She didn't know how to get it. I had access to data. I didn't know what it meant. And so we made a deal. I told her, I said, you teach me how to run a hospital and I'll make you the most tech savvy in the C-suite. And that's what we did. We went from the operations center. A lot of people don't realize that ECU hospital there in Greenville is the 17th largest hospital in the nation. It's over 1,000 beds. And we run a really big operations center. You've seen the helicopters. But from there, we went into our medicine service line, women's and children's. I was kind of the budget electronic health record data guy, but I had the opportunity to partner with a lot of really smart nurse leaders that I learned the business of healthcare through the data and mostly through the nurses that were teaching me. So I've always been forever grateful for my nursing colleagues, and I try to look after them. They let me step all over their toes when I was posterizing dashboards that looked real cool but made our service line look like junk, and they let me step all over those tools. But let's talk about AI, because I found myself back on this team 15 years later. When I saw the tool set that was coming out of ECU Health's analytics portfolio, I was like, oh my gosh. Because I've spent a living teaching nurses basic business acumen, some basic data acumen. It's a whole lot easier to teach a nurse leader some basic business and a little data than it ever is for me to be clinical. But I kept swearing I was going to sit for my RN just to see how close I can get. But they always laughed at me. But let's talk about AI, because this has been pretty amazing, our journey here at ECU Health. And again, this comes from really a servant heart and what I've learned about nursing. And it really is, AI supports a nurse. It doesn't replace a nurse. We like to define here at ECU Health that it helps deliver safer, faster, more compassionate care. But the nurse again, remains firmly in control of clinical judgment, licensure, accountability, all that good stuff. What it is, it's a teammate that drafts, summarizes, and retrieves information really quickly. A pattern finder across large volumes of data, and a tool trained on data, but guided by people, and best when a human reviews the output. And this is what I love about the business of nursing. And I used to talk about it to all my IT colleagues, and they're like, they don't know what they're doing. I was like, nurses are people. They're in the business of taking care of people. If you want to learn what's going on, you need to go talk to them. They're going to find out who your family is, who your cousin is, where'd you go to school, before they let you in the inner circle, because it's a very powerful place. But that's how you learn workflows. But again, what it's not, when I saw and started putting our position paper together, it is not a clinician, and it is not a source of truth. AI is not a decision maker, and it's not a replacement for nursing judgment at all. It's safe with patient data outside of approved tools, and it can be confidently wrong. And we all have our stories about it looks like it's for real, but it's not. And we understand about hallucinations. And I've been given these talks about Copilot. Here at our EHR, we have two sources of AI really that introduces nursing. That's tools delivered through Epic. And Dr. Lytle talked about the Epic tools, and you're going to hear us talk about those same ones: predictive models, sepsis, deterioration, readmissions, all of those predictive models that are really just using data to be able to give nurses an additional insight, but it doesn't replace judgment. And I used to talk about this all the time. We know in an academic medical center, when all the new residents come on board, the first 7 months, they're listening to the nurse and doing whatever the nurse says. I'd say treat AI just like a new resident is coming out of there. If he brings you a diagnosis that says, oh yeah, that's sepsis, and you know it's a broke toe, are you going to put that in your chart? No. You're going to tell him to go back and put in the order for a sepsis bundle or whatever it is you guys do. But you have to treat AI as an assistant. And many times it is a resident. I talked about it in here, whether it's a new grad or an intern that might be on your unit. It's just a complement to what you're already doing. But we talk about those tools that are inside Epic. Outside of Epic, we're a big Copilot shop. And the reason why is safety and privacy. We knew shadow AI was going to be out there. We knew people were going to use the tools. We started an AI community of practice early on with the free versions of Copilot, because Copilot gave us a green shield. And what is the green shield? That means I could put PHI or PI in there if I screw up, and it doesn't go out to train the models. And I always tell that story. Let's say I'm the chief nursing officer and I take my 3-year strategic plan and I go out there and put it into ChatGPT and I say, summarize it, turn it into a PowerPoint. It'll do that beautifully. But what did you just do? You just uploaded your 3-year strategic plan, and they can't get it back out, because all AI is, and this is the demystification, and I always say the Eastern North Carolina version, is that all it is doing is calculating the probability that two words occur beside each other based on the words that you put in there. No intelligence, none of that stuff. But they've downloaded the internet. These big companies, they've downloaded the whole internet. That's why Microsoft's got these big mega server farms, why they have to buy NVIDIA chips to hold every word that's ever been digitized. That includes YouTube videos and all the transcripts there. They got every digitized word. And so they put it in a big old server farm. They buy all the NVIDIA chips that are the fastest thing to process, and then they hook a nuclear power plant up to the side of it and calculate probabilities fast. That's what it's doing. But it's never calculated to say, I don't know. It's always calculated to return the lowest probability. And so if the lowest probability is 1 in a million that those two words occur beside each other, that's lower than 1 in 1,000,001. And so it's going to return the answer. There is no intelligence there. And so they just layer on probabilities across sentences and words as they find out. But that's all it's doing. It's calculating the probability two words occur beside each other. But we know that that's not that it's not safe to put those. And not only that it's PHI especially, but PI. And so we delivered Microsoft Copilot, and that's the difference. You get the same ChatGPT, now you get the same Claudes, but they're safely behind your tenant license. So the data that you use, the same models, they don't go back to feed the model. They stay on your side of your tenant license. And that's the BAA, the Business Associate Agreement that you sign with Microsoft, just like you sign with Epic. They give you a guarantee that you're not going to lose PHI unless somebody screws up. Same principle with Microsoft. And then we talk about nurse-led analytics. AI is already there in the nursing workflow in different types of places and available to nurses, but in no way is it asking you to work outside the scope of your license or to give you decisions that are superseding what you are deciding to do. But some really basic, we have the same similar sepsis models that we've been working here. Sepsis is a big deal. Trying to get at it early is really important. But how it works, you got a human in the loop every time. The model's flagging patients at risk, just like all the 9 indicators that you're supposed to keep up with sepsis in your head to try to follow along. They surface those 9 indicators, but it's not ordering the sepsis bundle. It's saying, nurse, do you want to order the sepsis bundle? And you have the choice. And in fact, those 9 elements will come in there and you can hyperlink right back to where it got the red flag for element number 2 or 3. And you can see the value and you can validate those before you order the sepsis bundle or however you're going to initiate a scope of practice. There's nothing that's autonomously acting on behalf of the nurse. And again, here at ECU Health, we have our AIM committee, which is AI in medicine. This is it's led by Jenny Malarkey, who's our chief legal officer. So our chief legal officer leads our AI committee. And we have clinical representation there, cybersecurity teams, all the folks, but licensed nurses remain as the decision maker at the end of the day. No tool is acting on behalf of a nurse. And I talk about this here. AI changes the tool, but not the license, the scope, or the accountability. We talk about AI doesn't expand the scope of practice. I was going to say it's delivered. And we talk about that. And I even did a little research on the North Carolina Board of Nursing. Like I said, the tool or the employer may restrict your scope of practice, but never expand your scope of practice. And this holds true for LPNs, RNs, and APRNs. AI is a software, but it can neither hold nor enlarge a license. A licensed nurse always stays accountable. Same thing as when it comes to any kind of technology failures we have. We now have downtime procedures. At the end of the day, you can still render patient care without an EHR. It ain't fun, but you can still do it. And it's the same principles that comes with AI. We can still render great patient care with or without AI, but it's an ability to deliver better care, easier, faster, and with the human in the loop. And again, clinical judgment remains human. Nurses lead and not follow, and adoptions build on community and coaching. And I talked about that early on. In our community of practice, it was pretty amazing. We had Dr. Waldron, our CEO, he sent out an email about 3 years ago, said, don't render patient care with AI. And in the fine print says, however, if you're interested in learning more about AI, reply back this email. And so Jason Buskirk, our VP of Data and Analytics, I'd already started a community of people using BI tools. We're a Power BI shop, and I've got nurses out there building Power BI dashboards, writing SQL queries, and all kinds of cool stuff. And that's the mantra that we run here at ECU Health. We don't have a lot of the resources, a lot of the other larger academic health systems. And so we build it. We build it in-house. And many times as a national model for rural health, I mean, our market is east of I-95. Those places don't come with a playbook. And so you figure it out and you learn. And again, I'm a testament to how I can show basic business acumen to nurses and how they run their business. But we started this AI community of practice from those 40-some emails. And what we did is we had Copilot licenses, but I ended up building a Microsoft form that you had to share an AI experience, any AI experience. But that demonstrated some basic competency on what you were doing with AI. And you earned a Copilot license. And I don't know if you've ever had a Copilot license, but when you do, oh my gosh, man, it makes your Windows, Word, Excel, PowerPoint amazing. And I want to get into a couple of studies after that, because I'm finding now the best AI adopters are the people who are already people that are collaborating, and the community is a testament to that. It started off with 40 people. People started sharing licenses. Nobody mandated anybody to use AI, but it started spreading like wildfire. But everybody knew about the Green Shield, and everybody knew about the tools that were available in Epic. We have great clinical informatics on our team and at ECU Health. And we have engaged nurse leaders in operations that are the ones that say, not only do I want to be the champion, I want to be the expert. Teach me what you know. And then I end up coming back and learning more from them than I ever will be able to teach them. But we shared a license, and actually our adoption rate stayed at 96% for Copilot. And Microsoft reached out to me. They're like, what are you doing down there? And I was like, just building this community. It's like, your adoption rate's like 96%. And at that time, I didn't even see the report. I didn't even know a report existed. And they said most of our Fortune 500 companies are at best 60%. And so they brought us down to Atlanta and told us our secret. I was like, it ain't rocket science. Why am I going to give a license to somebody and pay for it? And if they don't know what they're doing and not sharing their experiences, and the experience data we get is really informing our strategy. And so Microsoft made us a frontier firm, and we get first dibs at all kinds of cool stuff that comes out from Microsoft. But again, safely behind a tenant license. Epic was right behind us. We're an alpha site with them, so we're co-developing a lot of agentic workflows there. Agent-assisted workflows, human in the loop. Nothing's happening autonomously at ECU Health. There's always a human in the loop. And AI literacy is not data science. It's training is hard, because you're asked, how do you solve problems? Have you ever been to training? No, I've never taken an Excel class. I've never taken a PowerPoint class. It's one of these things where you learn on the job, and you learn from peers. And the more you create this community where people can reach out in a Teams channel and say, how do I do this? How do I do that? And it's not an IT person or an informatics person that necessarily has to answer the question. It could be a nurse up on 2 South talking to an ICU nurse up in the cardiac unit. It just creates that sense of togetherness and support for one another as we all are learning together. And again, every tool is governed before it reaches the bedside. We have any kind of agents we have in there, even our knowledge agents or chat agents. We have tools in place to be able to monitor drift. I'll tell you guys a real funny story about Bennett Bot. I created a Bennett Bot maybe about 3 years ago with Copilot, and I answer the same 40 questions like 4,000 times a week, it feels like. So I dumped all these documents in a big folder and put a chat agent on top of it. But back then, we didn't have any guardrails or any of those things in place. And I just shared it with everybody in the community. I said, y'all play around with it and see what happens. In the instructions of the agent, I said, answer as a fine Southern gentleman. And so people started messing with it, and they were saying, tell me why Bennett can't hunt. Tell me why Bennett can't fish. Tell me why Bennett's truck's a piece. Well, that model drifted from a fine Southern gentleman to a hee-haw redneck over the course of about a week. And the new AI guy came on board, and he said, your Bennett bot just called me Shug. Should I go to HR? And then we got a message from Microsoft. They turned it off. It drifted X number of standard deviations away from whatever. But again, that's how we figured out the guardrails, because there was none of those in place. But that was just a fun exercise in a chat agent. And now, 3 years later, we have guardrails in place. We got tools in place to manage drift. But that's the story I tell about why you can't put AI out there now. If it's predicting sepsis, yeah, that's a bigger deal than Bennett Bot answering questions. But at the same principle, it allows us to test and learn together. And we practice radical transparency within our community. We share all the good stuff. We share all the bad stuff. We share all the stuff we don't know. And we all jump in there and help figure it out. And it's pretty amazing when you crowdsource those solutions. But again, why AI doesn't compromise nursing practice? It's augmented, not autonomous. It's AI assist. The licensed nurse decides. Scope is unchanged. Software can't expand or transfer a nurse's legal scope. Accountability stays human. The nurse validates and owns every AI-supported output. Just like you would, you're not going to take the resident on what he says is sepsis. You're going to do your own judgment and usually tell him what to do. And documentation always stays trustworthy. I remember your question somebody's question about AI generated content. Yes, it will coordinate all your words, all your ambient listening. It puts all those words together, but only until the nurse modifies and agrees with all that stuff and hits insert does it load it into. And so there's still a human in the loop there. And then private and governed. We all talk about our tools being within our AIM committee, and really they're just hosted within the software platform that you deliver your work product out of. Nurses deliver their work products at ECU Health using Epic and a little bit of Microsoft 365 for nurse shifts and a little bit of Power BI for doing a lot of their daily huddles and escalating of activities. But again, all of those are not autonomous. There's a human in the loop with every one of them. And then I gave you guys some principles. I could sit here and talk all day long, but I did have some principles for your position statement as you guys sit down to start drafting. Again, define AI assistive as not autonomous. Require human oversight. It's so important. Affirm AI does not expand scope. That's really important as well. And keep nursing judgment central. Again, this is just a tool to help nurses render clinical care easier, better, and faster. Make privacy protections really explicit. Approved tools only. No PHI or PI in public AI tools that aren't governed. Expect organizational governance. Measure drift. Measure those types of, those tools are now becoming available where you can actually measure whether or not your agent is acting or is it drifting like Bennett Bot did. Involve nurses in AI decisions. That's easy at ECU Health because our nurse leaders are very quick to remind IT that they don't render patient care. That's the nurse's job. Your job is to give me a tool to do that easier, better, faster. And build AI literacy into readiness. Promote experimentation, celebrate wins. We all celebrate everything up at ECU Health that we figure out. And we posterize all the lessons learned because at the end of the day, we remind each other that it's not a competition against one another. It's all of us competing against bad patient outcomes. And I like to close with this. Nursing is and must remain a people business, and the best use of AI in nursing is not to make care less human, but to give nurses more capacity to be present with patients and families. And I'll stop there. I'd love to answer any questions if you guys have any.
Thank you so much, Mr. Wall, for your presentation. Committee members, are there any questions for Mr. Wall? Okay, seeing none. What about staff or staff?
I actually do not. Thank you, Dr. Ingram. Mr. Wall, I tend to be rather chatty as well. So I imagine that a Meredith bot would evolve
Yes.
to. Not quite sure that I want to see what it would evolve into, but I think that the principles and the guidance that you provide, and then that you already have this established team, is really encouraging to see that you are truly looking at it not only as a tool and helpful to the nurses, but also it's a safety issue. And
Absolutely.
you are stressing that at its core, it is nursing judgment and it is not replacing. And I think that that's just, as a patient, as a regulator, those are the things that we want to fall back on. And you guys have already embraced that. So
Absolutely.
kudos to ECU Health.
Thank you. Thank you.
And I'd just like to echo what Meredith said. I mean, the presentation was phenomenal. We have a draft position statement. I've already asked for your slide for the 10 items that you've included. I think it was 10 or 8 items for us to go through and check off those suggestions. I think the majority of those are incorporated in our position statement, but it'll give us definitely a
Awesome.
talking point for the committee members to consider as they read draft position statement. Thank you so much. Go
Absolutely.
Pirates.
And I think I even have a Word version of a position paper out there. Hopefully y'all can copy and paste and make it easy, or use AI and turn it into something easy. So y'all can get back. Thank you guys. It's awesome.
Yes.
Thank you for what y'all do too, seriously.
Absolutely. Thank you again, Mr. Wall.
Thank you.
Thank you, Dr. Lytle, and board staff. Thank you so much, Dr. Luisana. Yes, okay. And Ms. Thompson and Dr. Caparel. Thank you all so much for sharing your expertise as the committee continues to move forward with this important charge. And so I will now turn the meeting over to our education consultant, Dr. Anne Marie Milner, for her presentation on the role of AI in education.
Great. Hi, everybody. Thank you, Madam Chair. I appreciate letting me discuss education, AI literacy in education. So as you heard earlier, AI is becoming increasingly important in healthcare, nursing education, and practice. Common themes that I found across the AI literature was AI literacy, ethical use, faculty readiness, and professional accountability. The survey findings also reflected these themes and emphasized the need for clear education and guidance so students, faculty, and practicing nurses can use AI safely, effectively, and ethically. So AI has become an important issue in nursing education and healthcare practice, and much of the discussion is on AI literacy. AI literacy involves more than knowing how to use AI tools. It includes understanding AI's capabilities and limitations, evaluating AI-generated information, and recognizing potential bias, as Dr. Steele said, and applying professional judgment. Consistent with these findings, survey respondents expressed concerns about inaccurate or incomplete AI output and emphasized the importance of verifying AI-generated content before using it. So beyond understanding how to use AI effectively, it's important to use AI ethically and responsibly. So survey respondents emphasized the need for clear guidance and ethical AI use, including responsible use policies and professional standards. They also expressed concerns about academic integrity and the potential for AI to undermine authentic learning and when used inappropriately. These concerns reflect the themes identified across the research, including bias, confidentiality, transparency, accountability, and the need to critically evaluate AI-generated information before using it. So AI has become more common in education, and another emerging theme that I found was, how should it be disclosed? So aside from telling students not to use it or just to reference AI, researchers view disclosure not only as an acknowledgement of AI use, but also as an opportunity to help learners explain how AI contributed to their work. So beyond using AI ethically, researchers also emphasize the importance of transparency regarding when and how AI should be used. So this is just an example I found in the literature. AI Disclosure Coach is presented as just one example, there was several, of a structured disclosure framework that promotes transparency and reflective practice. The framework encourages learners to document AI use, describe verification activities, explain revisions, and clarify where professional judgment influenced the final product. Regardless of the specific framework used, the broader theme is to maintain transparency and accountability and to use human decision-making when AI tools are incorporated into educational activities. So what are some of the benefits AI can use in nursing education? The literature highlights several potential AI in nursing education, including clinical simulation, adaptive learning, personalized feedback, and educational content development. These approaches may enhance student engagement and confidence and help prepare learners for technology-enabled healthcare environments. However, the literature also identifies a number of challenges and risks. Although AI presents promising opportunities, researchers also note concerns about misinformation, privacy, academic integrity, and the impact of AI on critical thinking and clinical reasoning. The literature further emphasizes the need for faculty preparedness and institutional readiness to support responsible AI integration. So across both the literature and the survey respondents, faculty experience, preparedness, and confidence emerged as important themes for the responsible AI integration. So several studies indicate that nurse educators often have limited formal training in AI and have varying levels of confidence in using it. However, faculty are increasingly expected to guide students in ethical use, verification of AI-generated information, and professional responsibilities related to AI technologies. But also for the faculty and for nursing programs, it can be used beyond the classroom, which is a plus if I was still a director at nursing, because AI can help organize data, identify trends, generate reports, and support accreditation related activities. However, faculty review, it must remain foremost in the AI that is produced from all of the information you put in. Just like Mr. Wall said, you're only as good as the information you put in. But across all applications described in the literature, one consistent message remains. Perhaps the most consistent finding across the literature is the importance of maintaining human judgment and accountability. Researchers repeatedly emphasize that AI can support information gathering and analysis and decision-making processes, but it does not replace professional expertise, clinical judgment, ethical reasoning, or responsibility. AI integration continues to evolve several areas, and some of those areas need ongoing assessment. So beyond AI literacy, other topics were discussed, including workforce readiness, faculty training, ethical use, disclosure policies, and the evaluation of AI integration. Consistent with these findings, some survey respondents also supported incorporating AI into nursing curricula, simulations, course design, and professional development. Together, these findings highlight several key themes across the literature. The literature presents a balanced view of AI in nursing education, with researchers describing both opportunities and challenges. AI is generally viewed as having the potential to support learning and workforce preparation, while also raising questions related to ethics, accountability, biases, privacy, and professional judgment. Several survey comments also connected AI use in education to downstream effects on patient care, emphasizing the need to maintain rigorous and educational standards. So in closing, In conclusion, evidence from literature and the surveys demonstrate that artificial intelligence can contribute positively to nursing education and practice when integrated within robust educational frameworks and guided by ethical oversight. Artificial intelligence needs to be integrated carefully and ethically to assist, not replace or substitute, professional judgment, clinical decision-making, and accountability. This will help ensure that technology supports the delivery of safe, high-quality nursing care. As artificial intelligence continues to influence nursing education and practice, the board's mission remains unchanged: to protect the public by regulating the practice of nursing. And then Brad, we had a little video that Miss Paulette Hampton found for us. So let's see if we can play that video. Okay. Oh, here it is.
When I started nursing, notes were handwritten, medications were transcribed from the doctor's orders on little sheets that went down to the pharmacy, and there was an opportunity for error. Nursing has evolved so much in my career, and AI was just a next step. The technology is part of who we are and what we do, and we want to be those innovators at the table as AI moves into healthcare. The push to an electronic health record was really to improve the recording of what happened in healthcare. The beauty of that electronic record is that we can go back then and look for trends and data, and that's where artificial intelligence is really going to be making a difference in the future. Nurses are obviously busy in their profession. AI has the opportunity to improve those day-to-day management tasks. So things like ensuring that a bed is available, or ensuring that medication is ready for discharge, or having those frameworks and checklists that AI can pull and give a reminder that's embedded into that electronic health record that really can help focus and drive the efficiencies of nursing. Healthcare monitoring is booming. They have created digital tools as small as a Band-Aid that you can put on your chest and monitor your heart from a remote location. It's constantly feeding their information to their provider, thinking about all of the data in that 1 week and how we can look at trends in the heart rate and other monitoring. So this opens up a whole opportunity for telehealth. It's one more tool that we can use to create our treatment plan, but at the same time, we never want to lose that component of nursing and caring, which the humanistic point of view is so important to us as nurses, and ensuring that our clients get the best care and advocating for their care. We always want to keep that human in the loop. But with artificial intelligence, we have to be transparent in how we're using it, how we're expecting our students to use it, telling our patients how we're using it so they have that clarity, and how you're using that AI, as well as protecting their information. Informed consent is very important, and then having that transparency component so that they know how we're using it and why we're using it and what the benefit is to them. If you told me when I started nursing that I would be using artificial intelligence in my everyday practice, I would have thought you had two hats. With the ability to teach students through healthcare simulation or virtual reality, and I can't even tell you what next year is going to bring, but I know that it's going to be exciting. It's going to make a difference in people's lives. It'll make a difference if you are learning at ASU Online. Thank you, Brad.
Includes mine.
Thank you, Dr. Milner. Are there questions for Dr. Milner? Questions? So I have, I guess, a few comments. Thank you again for your presentation. I think one of the key things that you mentioned for education is faculty preparedness. And so nursing faculty coming from education, we have to be, because our students are coming having like expertise, if you will,
Yes.
already. They're going to use it regardless to what we say. But if you as faculty are not prepared, or we as faculty are not prepared, we won't recognize that AI has been used. So thank you for saying that. And also the ethical use of it. And I think several of our presenters have already indicated that the ethical use and then guidance and policies have to be in place. And I believe, I don't recall who said it, and you may have said it or mentioned it too, Dr. Milner, about the policies typically indicate that they can or they cannot, and so we, as nursing faculty, have to be a little more specific in that regard, because again, they are going to use it. They're using it. They're really great with using it. They can teach us. They often do teach us, meaning students, about how to use it. And then we think about tools to let us know if AI has been used when we indicate that it can't be and they're not reliable, according to the literature. And then that with that, when you have a student, so I'll just speak from an experience that I had, it's AI that they're using, but because they know you're going to ask them questions, So they read up on the AI presentation that they have developed, and then they can answer those questions. And of course, we take them to clinical, and then they do the hands-on. So helps to reinforce that clinical judgment and all those things. And then workforce readiness. You mentioned Dr. Milner. I have a program advisory committee. They are wonderful. And I remember asking them a question about how do we prepare our students, because we want our students to be prepared, of course, for clinical practice. And in terms of AI, what should we do? And I didn't get a lot of feedback, but I anticipate with our forthcoming meeting that I will have a lot more response from my program advisory committee. And so thank you again for your presentation. If there are no further questions or comments from committee members or staff, then I will ask Dr. Milner to introduce our next speaker.
Okay, I'd be happy to. Dr. Lindsay Draper is an Associate Dean for Faculty and Academic Support Initiatives and Clinical Associate Professor at UNC Greensboro School of Nursing. In this role, she provides leadership and oversight of systems that ensure compliance with university, Board of Nursing, accrediting bodies, and clinical agency regulations, while also leading faculty onboarding, orientation, mentoring, and AI initiatives. Dr. Draper is widely recognized at both the state and national levels for her leadership in integrating AI into teaching and learning. She has delivered more than 15 invited and peer-reviewed presentations in the past year focused on practical, ethical, and scalable applications of AI in higher education and healthcare. She has developed and implemented faculty development workshops and continuing education courses that support educators in the effectively and responsible incorporating AI in their teaching. She recently collaborated with partners across the UNC system to develop the Foundations of AI course, which is being implemented the fall across the UNC system school and is designed to advance AI literacy among students statewide. As part of this initiative, she led the development of the AI and Health Science module, which highlights discipline-specific applications in AI across the health fields.
Good morning. Thank you for having me. I am Dr. Lindsay Draper, and it is a pleasure to be here with you all this morning. So at UNCG, our educational approach is that AI literacy is not optional. It is now part of our professional nursing competence, and it is our job as faculty to begin having those conversations and to teach our students all about AI and AI literacy and how to use it appropriately and responsibly. So as we've talked many times today, we know that students are going to enter the practical and clinical settings where AI is here and even more so in the days ahead. So our goal is to prepare nurses that can use AI, but also so that AI can add value so that they can devote time, dedication, and energy to what we think matters most from a people perspective is that critical thinking and clinical judgment, empathy, communication, and building relationships. So our stance is that AI should augment nursing practice, not replace, and definitely not replace that clinical reasoning and judgment that is so foundational to nursing practice. So at UNCG, we do have required AI literacy education that is embedded into our courses. It does cover foundations of AI, safe and responsible uses, and then academic practice as well. So this is everything from the beginning of what is AI, how does it work, what's the difference between AI and generative AI, what are those benefits, challenges, limitations, what are the HIPAA concerns that you should be concerned about. We even talk about what's the difference between open and closed AI systems, so that way we can begin to prepare students of how AI is using the information that they are being fed into the generative AI tool. So please don't put your dissertation in there unless you want it to live in the world. Going a little bit further, then we start to talk about how to build a good prompt. What does a prompt look like? How does the quality of the prompt impact the quality of the output that you're going to get? And then we began to talk about how AI is being used in practice, as well as what constitutes plagiarism and academic integrity. And yes, all of those concepts still apply when you use AI. So how important it is to make sure that you do cite your AI use. We do teach our students that AI is treated as information to evaluate. It is not the authoritative answer, and that you must verify, challenge, and correct any information that is incorrect. So what we do is we have an AI literacy assignment that we have built into our courses in which students develop an initial prompt based off of what they have just learned about what makes a good prompt. They develop a prompt related to nursing or healthcare and then submit it into an AI tool of choice. And then, of course, they get that nice outcome. And so they will use the AI response and the literature that's available, as well as practice and quality guidelines to evaluate the accuracy, the relevance. Are there any biases? Was it useful? Were there gaps? All kinds of things. So who's better to ask how to build a better prompt than the AI tool itself? Our students will then say, okay, how can I improve my initial prompt so that you give me a better response next time? It will generate that second response, and then our students do a comparison. So they compare the first prompt they gave to the second, as well as the quality of the first AI response to the second. Again, with every first or second iteration, they are always using resources to validate that the information that they are being given is correct and where those gaps are. Now, what we do is we have our students submit the transcript of their entire interaction with AI so that we can assess learning. We want to see the entire process of where they started, where they went, and how that shifted over their interactions with the AI tool. And then, of course, reflection, such a key piece of learning. So we have the students reflect on that quality. What was the differences? What are the values? What are the implications for nursing practice? And how much is the value of human oversight important when we use AI? So some other examples of how we use AI in our programs are through AI agents, also known as chatbots. So we have developed AI tutors. This is especially important for our pre-licensure students because it provides individualized feedback and assistance for whatever the student may need. So for example, if they're not understanding congestive heart failure, they can go to the AI tutor and say, can you explain this in a different way? I'm still not understanding it. Help me again. Help me understand how beta blockers work. And it does a really good job of explaining those difficult concepts and goes a little bit deeper to help build that bridge that maybe they weren't able to comprehend it during the class time. They can also ask the AI tutor for sample test questions. What better way to prepare for an exam than to say, let's try some test questions? The AI tutor will help to identify where those gaps are so that they can then develop their study plan accordingly. We also developed AI course assistants. This is a great tool to help students just clarify assignments and due dates and expectations in the course. It is 24/7 assistance, which is really important for students that might not be taking classes during traditional Monday through Friday, 8 to 5. They get the assistance exactly when they need it. And the students have provided very strong feedback that has been a huge benefit for their learning. It's also been a benefit for faculty because all of those questions that are answered in the syllabus are now being answered through the AI course assistant, and it has reduced the number of emails that could have been answered if you read the materials in the course. We also have developed AI communication coaches. This supports professional writing, but also can be used for professional interviewing skills and all types of communication. And I will talk a little bit more about this particular tool in a few minutes. And then AI supported simulation. So not only to develop simulation cases, but within our nurse practitioner programs, it also is being used to help our nurse practitioner students practice interviewing. So they have an AI simulated patient and they conduct a health history. The agent is very strongly guardrails in place that they have to answer the question, whatever the question is. Do not guide the nurse practitioner towards any certain diagnosis. You're going to go with the flow and answer what they ask. When the student has felt as if they have enough information, they will then formulate their diagnosis, and then they will create their care plan and their SOAP note. Once all of that is completed, the AI tool will provide some feedback on the entire process, the process of what's good about the SOAP note, what might be missing, maybe how the communication came across from a patient perspective and how the questions were asked, how that may be interpreted from a patient response. It will also help the student to reflect on, why did you ask this question versus that question first? Or you asked this question, can you tell me more about what you were thinking, what led you to that question versus another question? With all of these tools, we do have students submit the transcript so that we can assess their learning, but also assess the quality of our chatbots that are being used so that we can continuously refine as needed. So far, we have not had any rogue agents. But it does require constant monitoring and supervision, and it's our place as faculty to make sure that the tools that we have developed and implemented are delivering correct and accurate responses and what we think we should be teaching our students. We also have lots of examples from in-class activities to make active learning in the classroom, where students can do group work or individual work, where they're engaging mostly with generative AI, ChatGPT, and Copilot. So this is the example of the AI communication coach. This particular assignment is used with our DNP students, again, to practice professional communications. So this translates to practice as well. We have our students first write an email, a memo, and an executive summary on their own. So they receive class content about all of these professional writing styles, and then they draft their own independently. And then they use an instructor developed AI coach, Kate, the communication coach, who has been given very structured guidelines about what the tone and structure should be for each of these types of communications. And the students will say, hey, Kate, can you give me some feedback on this? Or they can ask very targeted information like, Kate, if you were a nurse on the unit, how would you interpret this email? And so they can ask a series, any question they want to Kate, but then they have to decide which information they're going to incorporate into their memo or email or executive summary, and maybe which recommendations they don't want to implement. And so then the students can revise their work as they see fit. At the end, we ask them to submit a series of items. So in the portfolio, they submit their initial drafts, the entire communication with the GPT, their revised drafts of all three of the item styles, and then a reflection as well. And it is very interesting to see from the start to the end, the quality of what's being submitted has improved dramatically with the implementation of Kate, the communication coach. What is interesting is the student reflections. They have been very insightful. Students will say, I didn't know I came across this way, or this is so helpful for me working with teams in the clinical setting, or it's important to understand how other people could interpret the message, and that's not at all what I meant, or maybe I need some more data to support this executive summary to make my case. So the students have actually really appreciated this tool and have asked to continue using this tool even beyond the assigned course. We also have some faculty using an AI agent in post-conference within the clinical setting in the undergraduate courses. So the faculty will develop an AI scenario, and so when the students engage in the agent, it will have some basic information for the patient. What's going on? What's their results, medications, vital signs, things like that. The students then have to identify the cues, and then they have to begin to interpret those cues. Now we're going through the clinical judgment model in post-conference. So once the students determine what they think might be going on with the patient, they develop a nursing care plan. And then they compare their care plan with the care plan that the agent has created. And then through conversations, they can talk about, well, what things might be correct, what things might be incorrect, what should we do differently, what are those patient-specific factors that AI didn't pick up on because AI doesn't know everything about an individual patient. And so it's really helped to build those critical thinking skills in post-conference. It also has some faculty-guided questions that they can talk with the students about what information was most clinically significant, what was missing. And our goal is, again, for the student to demonstrate independent clinical reasoning. They cannot rely on AI to do the job for them. This is simply just to enhance and to build upon the knowledge that they've already gained. So academic integrity and transparency. At our institution, instructors get to decide whether or not they want to implement AI in the classroom and to what extent. So we do have responsibilities for faculty and for students. So faculty must communicate if AI is permitted and if it is not permitted, the expectations of use within the class, and then as well as how AI should be documented or cited within the particular parameters of the assignment. Also designing assignments that preserve student intellectual development, and sometimes that means that it is not using AI. So we've learned traditional discussion boards, multiple choice questions that aren't being proctored, AI can do those very easily. So as faculty, it's our time to change how we teach. We can no longer do those assignments the way that we've always done them in the world of AI. Also, AI does not outsource thinking. So we have to make sure that our students are thinking before they start using AI and after they start using AI. From the student perspective, they have to follow the instructions and the expectations, always cite and understand that AI policies are different depending upon which program or course or even which assignment you might be in. And so always we tell students from day one that if it's unauthorized or unacknowledged, it can be an academic misconduct. And that rises all the way up to the institution. So what we do is for each assignment, some faculty will just say, you can use AI in all of my assignments. Some say, no, you cannot use them in any assignment in this course. Others might say a tiered level. So it's prohibited, it's permitted, it's encouraged, or it's required. And oftentimes in academia, we'll see this as a stoplight that you can include in the top corner of the assignment. So it creates a visual cue to students. Red means no AI. Green means have at it, and yellow says let's talk about some limitations or how you should or should not use it in this assignment. Faculty, how we might use transparency is naming the tool that was used. We can also ask students to describe how they use the tool. So for example, in full transparency, the content of the slides today is my own information. The slide itself was developed by ChatGPT. So that's how the students we would demonstrate that within our own academic slides and content of material and expect students to do the same in return. We can also ask students to provide their prompt or interactions, as I've already discussed with the transcripts, and then through reflections of explaining what did you incorporate, what did you not incorporate, why, what were the limitations, errors, biases, and that kind of thing. So how does this intersect with occupational licensing requirements? All existing nursing laws, standards, rules, and expectations remain in place. And so we stress that with our students on day one. Do not put any patient information into any AI tool, period. But what AI does not do is it does not expand the nurse's legal scope of practice. Just because you have access to Dr. GPT does not mean that you can now diagnose and prescribe. It does not establish competence. Okay, AI cannot teach our students. We have to teach the students. It builds on the competence, but it does not establish the competence in the first place. It does not replace our nursing assessment or accept responsibility for anything that happens or does not happen because of AI use. Nor does it eliminate documentation or communication requirements. So the nurse is still responsible for all aspects of the nursing process, maintaining HIPAA, and the final decision or judgment that you make, whether it be in the clinical or the classroom, is your own. So that kind of ties into the key legal principles. I'll kind of skip to the bottom of the slide. For our students, we stress throughout the entire program that AI can support your learning. It does not replace your critical thinking, critical judgment, or learning in the first place. For educators, we have to select the appropriate tools and boundaries and know how students are using it so that we can help them to use it appropriately and correctly. But also, we have to demonstrate knowledge of AI use ourselves, and we do that through continuous learning. So at UNCG, we held a faculty retreat back in 2024. It was a conference style retreat. And so faculty would go through each room. We had three breakout sessions at a time, a total of 7 or 8 different total sessions. And so they could learn from experts in the school about how to use AI in every role of their faculty role. So how to use it in teaching, how to use it in curriculum design, how to use it in administrative, how to use it in research, how to use it within service. And so that was our first step in faculty development. Since then, we have committed to ongoing faculty development and a series of professional development opportunities for faculty about any upcoming new uses of AI. We have our faculty presenting to faculty about how they are using AI within the classroom and within their own realm of what they do. And we have actually turned this into an IRB where we collected data using the technology acceptance model of how this particular strategy has shifted acceptance of AI over time, from before the workshop retreat to after and then ongoing. So a few last key takeaways. AI has to be intentional. We have to understand the limitations. We have to demonstrate independent thinking and judgment. Professional accountability remains. But one thing I do want to point out is preserving the human role, which we've heard a few times today, that an AI-ready nurse knows what the technology can do, what it can't do, when it's appropriate to use it or not, when it should be questioned, and that professional accountability always remains with the nurse. So we feel that it's our responsibility as educators to prepare nurses who can use AI safely and thoughtfully without replacing their thinking, their judgment, and then that way they can shift to more important things like empathy and human interactions, which really help to define the nursing practice. So with that, I will open it up to questions.
Thank you so much, Dr. Draper, for your presentation. Are there questions for Dr. Draper?
You know, how do you know if they're not permitted to use AI with the, diagram that you had, how do you know they didn't use it? Like, I mean, we can write a policy to say not use AI, but how do you know that? Like,
Exactly.
how do you govern that?
Exactly.
You know what I mean? So like, help me understand, because
Exactly.
I have many workarounds around that as a student.
And I would say in the School of Nursing, we are probably one of the schools that have adopted AI more so than the other units on campus. But for example, like for students writing their dissertation, that's going to be a do not use AI. We can kind of tell if it looks like it's AI written. So the university is working on some policies and guidelines about how we enforce academic integrity violations. But what we have found, especially in the School of Nursing, is having a conversation with the student to say, help me help me understand, walk through this. What was your process of developing this? So like, for example, if a student writes a discussion board, you can tell the AI wrote it. What you may not tell is that it looks like a great citation. There's references at the bottom. There's in-text citations. Oh, it looks pretty. Until you click on the link, the DOI link, and it doesn't even exist. It's not a real article. So in that situation, having a conversation with the student to say, here's the issue I'm having. This article that is listed here that's all cited, I can't find it. Can you help me to find it? Oh, no, it's not there anymore. Okay, can you walk me through the process of writing this? Well, I wrote it and then I ran it through this tool and it changed all of my references. Okay, so as we learned in our AI literacy, you're still responsible. And so most of the time when we have a conversation with students to say, we're wondering how, and the students, knock on wood in our case, have always come clean. And so that's a good learning moment that we can have a conversation to say, people know. We'll have to talk about consequences and what's appropriate for this situation. But in general, in the School of Nursing, we have had faculty more lean against, let's help you to use it and use it in the right ways.
Additional questions? Comments? Yes, absolutely.
Thank you, Dr. Draper, for coming today. I appreciate it. So one of the questions I had was in regards to students that have graduated from your program and are now in the nursing workforce. Have you received any feedback from those individuals regarding the AI literacy course that was taught in your program and the other assignments? And was it beneficial for their nursing practice?
Great question. We started the AI literacy course summer of 2024. Summer of 2024. So most of our students who took the AI literacy course are still in our programs. But what we have found is at that point, they were in the first semester or two of their learning. And now that they are coming back, I'm seeing them again later on in the program for a different course. Anecdotally, they're saying, we're so glad we had this information. We wish we would have had it earlier and sooner, not even in education, but in practice in general. Also comments about how can we share the same information with our colleagues who might not be in school right now. Maybe they graduated before this AI literacy course came about. So I do think it's important that we work with our clinical partners to ensure AI literacy is not only in education setting, but after and ongoing as well. But we have had a few students who took the AI literacy as part of their undergraduate, and then they decided to continue on in our master's program. So that kind of gave them an edge. But I do think that that is something that we should consider adding to our alumni surveys, possibly, to kind of get some more insight on that. And as the UNC system course rolls out, that will be additional information. So how that's going to layer is the UNC system AI course will be for freshmen coming into the university, and then they will get our nursing specific when they enter the nursing program, both at the undergraduate and graduate levels, so that we can tier that and continue with what we expect of them when they enter the nursing program. So great point.
Excellent. All right, so no additional questions or comments. Thank you again,
Thank you.
Dr. Draper, for an excellent presentation, for your time and your perspective in terms of AI in nursing. We will take a shorter break, and then we will resume. So we will come back at 11:30. Thank you. The Education and Practice Committee meeting will now resume. I will turn it back over to Dr. Anne Marie Milner to introduce our next speaker.
Thank you. Ms. Alana Goodell is a nursing educator and critical nurse with over 17 years of clinical experience and almost 8 years of academic experience. Since 2021, she has served as nursing faculty at Wake Tech Community College, Martha Mann Smith School of Nursing, where she teaches senior level ADN students in complex health concepts and LPN to ADN nursing transitions concepts. She designs NCLEX aligned assessments, next generation NCLEX case studies, and simulations focus on clinical judgment and licensure readiness, and is a faculty lead for Wake Tech's 2027 ASIAN accreditation. Alongside her teaching role, Elena continues to practice as a critical care nurse at UNC Rex Hospital, providing rapid response and clinical decision-making support across the hospital units. She holds a master's in nursing education from Indiana Wesleyan University, a bachelor's of science in nursing from UNC Charlotte, an associate's degree in nursing from Wake Tech Community College, along with several active certifications in CCRN, ACLS, BLS, and NIHSS. She recently completed a generative AI foundation certification, in which she has informed both her own responsible use of AI and AI integrated curriculum, assessment, and policies she has developed for nursing students. Welcome.
Thank you, Dr. Milner and everybody. So just thank you for giving me the opportunity to speak today. Over the past year, I have developed and revised learning activities and course guidelines that address how students interact with generative AI in academic settings. My purpose today is not to advocate for or against AI, but rather I would like to share how nursing education can teach students to use these tools responsibly through verification, disclosure, professional judgment, and accountability. I also hope to offer perspectives on how these same principles can be used in your regulatory discussions. Let's see if I did that right. Okay, there we go. All right, across both my RN and the LPN to ADM programs, the core principle I teach is straightforward. AI assists with drafting and organization, but students remain accountable for verifying that information and exercising independent professional judgment. Students are taught AI output should be treated as a starting point for analysis, but not the authoritative resource. Before any AI generated information is incorporated into coursework, students must compare it against authoritative references such as evidence-based literature, course resources, or even your own website, the North Carolina Board of Nursing. This mirrors clinical reasoning because students are learning to gather information, evaluate it, verify it, and make decisions based on what they've gotten from the AI output. Educational goal is not simply learning to use AI, but to strengthen clinical reasoning, accountability, and safe decision-making when it comes to patient care. So one activity I have is actually related to the Board of Nursing. And you guys change your website every mid-semester. So I was like, I've got to do something. So I have this part where they have to go in and look through your website and find questions and answer questions. And then usually like in March, I get an email, Miss Goodell, they've changed it. So I said, this time I'm going to have a prompt. So what I have is I'm going to pilot this fall as a prompt. The students put the prompt in and they can use whatever they want, Claude, Chat, Gemini, Copilot, whatever resource. They take the prompt, copy what the output is from the AI, and then they have to sit there and go through your website and verify that this information is up to date, correct, and then they reflect on learning from AI. Yes, it's great. It's really good to assist you, and it wrote out this prompt, but I need to go back and do my part. So that's what I'm piloting for this semester. But they also learns how to navigate an authoritative site because a lot of our students don't know how to look for some of these resources. And then it shows you the AI generated responses can appear credible, but there's still errors. So it looks good, but there's still errors attached. The educational value comes not from what AI produces, but their ability to evaluate, verify, and correct information, reinforcing that accountability and using clinical judgment. Another thing I did is our school provides flexibility in establishing AI expectations for coursework. So what I did for the students is I created this, and this is what's on the slide. The students will see this, a verification, disclosure, and accountability of what is acceptable, where AI is acceptable in generating outlines, brainstorming ideas, verifying sources, but it's required that you disclose if you use it. And we are going to ask that because we see that on the clinical evaluation tools, which is really what our senior students submit to us. And you can tell they use $20 words, their voice is gone, they give you these examples. So the thing is we know they're going to use it. And I've had some ESL students tell me I use it because I'm ESL and I feel like you wouldn't understand what I say, but I tell them you lose your voice. So it's okay if you use it to maybe help you focus that idea of what you wanted to share from that clinical experience, but make sure you tell us you used it because I'm going to know. Unacceptable uses are unverified submissions, replacing reasoning and clinical documentation. And again, we're going to look at it. If it's not disclosed and we can tell it's AI, then we're going to require resubmissions. The central expectation that students remain responsible for accuracy, integrity, and professional quality of all submitted work, regardless of whether AI was involved in the drafting process. The faculty also need to be responsible. I did my generative AI certification because I felt like it was important that I stay ahead and understand, and half the certification revolved around bias, ethics, and legal practices for AI. So I feel like that was very important. It taught me a lot and has allowed me to go and be able to teach my students how to use it. I believe that we have that responsibility as faculty to use verification, disclosure, and professional judgment. I also have to review anything I put in. I need to review it to make sure it is accurate, that I'm telling the students correctly. I use it for games, a lot of the games we do. But I should hold myself to the same standard I hold my students when it comes to AI. Sorry, I'm getting a little at the end. Okay. Y'all said 10 minutes. I literally took it as 10 minutes. I was like, I'm done. So as AI becomes increasingly available in education and healthcare, which I think we all kind of realize, I would encourage in consideration of frameworks centered on competency, verification, disclosure, professional judgment, and accountability. Educational experiences that teach students to evaluate and verify AI. I think that's important for both academic and clinical decision-making. Clear expectations for disclosure, academic integrity, and responsible professional conduct. Continued emphasis that nursing students remain accountable for their decisions and their judgments, regardless of what type of technology they use. And faculty modeling the same standards of verification, disclosure, and professional responsibility that we expect of our students. Public protection should always remain the priority. And in closing, here's my disclosure that I use Claude to help me because Claude helped me develop the prompt. And I have when y'all sent the email, I was like, oh my gosh, this is just so much stuff. So I went to Claude and said, I need help. And it helped me out. And then I revised and looked it over. But this is I feel like preparing future nurses to critically evaluate information, verify its accuracy, disclose appropriate use, and remain accountable for their decisions can support both safe practice and high quality nursing education. So I feel like we shouldn't run from it, but we need to learn how to embrace and use it properly. And thank you for the opportunity to let me contribute. That's it.
Thank you so much for your presentation and especially for sharing your disclosure regarding the use of AI in preparing your presentation. Are there questions?
Can you clarify, it was hilarious, but can you just clarify which part of the email was
that second question?
extensive?
I was like, what are you asking of me? The first question, I was like, okay, I think I have an idea. I knew what I wanted to present, but I had multiple ideas. So Claude kind of helped me be like, why don't we use the assignment that I helped you create, which was the Board of Nursing. Because I've used it to do games. I'll load in games I create for students, like scenarios and stuff to have it clarify that the language is the same, to make sure like the fonts and that it's accessible. Then I got to that second question. I was like, I don't know what to say. I honestly, like, what are you asking of me? And then when it spit back out what couple of different options of what you asked, I understood better that it was, oh, you're asking me how I feel like it should be regulated. And then I was like, oh, this is about accountability and professional judgment and that faculty. So it was just the way the question came off. And maybe it was my wording, my reading it, but it was nice to kind of have that because it took some of the nerves away.
Okay, thank you.
You're welcome.
Are you also this jovial with your students?
Oh my gosh, they say I'm a mess, yes.
Thank you.
Oh yeah, you're welcome.
Dr. Shaw, did you have? Okay. Yes, Dr. Kisley.
Yes, I just have a quick comment, and I really want to thank you for bringing forward the responsibility of the academic educator. We say we claim we can see the AI use in our students. They can see it in us as well. And I think modeling that behavior is one of the first steps moving forward so that they do the same thing in kind. So
Yeah.
thank you.
I feel like there was just like this big, like, don't use it. But then we add new faculty that were using it. And I felt like you can't play both sides of the fence. But I feel like it's responsible for us to say, we know you're going to use it. I'm going to use it. Make sure you validate it just like I do.
So it works both ways. Yes, Dr. Moore.
Okay. Hello.
Hello.
Full disclosure, I hired her for Wake Tech. She's one of my faculty members. So how are you teaching other faculty? Are you doing it or do they have?
I've been
what's going
working
on?
slowly with other faculty. My coworker, I got her into it. And so we have developed games for our clinical group meetings that, like, one of them's an RCA game. One of them's like, you're the charge nurse today. So we've been roping her in and then other faculty. So I've been slowly trying to go around and work with faculty like Dr. Shepard. I've showed her how I've used it so she can create things to give them ideas on how to develop prompts. That's the biggest thing, is the prompts.
In Wake Tech policy for the college, do they have anything about
It just
AI?
says it's up to you to make the guidelines.
Okay. All right. Thank you.
Any other? Yes.
So similar to my question I asked earlier, have you had the opportunity to talk with any students post-graduation regarding their experience with the education that they received while in your program that it facilitated their nursing practice, help them assimilate to nursing practice?
I have, because I still work at Rex, I run into students all the time. And I have talked to them. Sometimes what I hear more is about how I've taught them how to use it to develop questions to prep for NCLEX and how that helped them as well for studying, like how to prompt it and things like that. But not a whole lot of, this is how this has helped me at this setting.
Thank you.
Okay, if I just may add one thing. Again, I'm the chief legal officer, so it comes from that lens and that perspective. Love your disclosure.
Oh, thank you.
I just think it's fantastic. I tend to do disclosures at the beginning of my presentation, so this would check all of the boxes. And then the second thing was, can we get a copy of the Board of Nursing simulation that you have, the question with AI? Because I would love to take a peek at it.
Yeah, this is a pilot, so I will send it to you. It's really cool because they put that in, then they've got to verify, then they evaluate what they think, how AI made them feel, but then they have to go to other things that relate specifically to the Board of Nursing, and then they do a general overall reflection of what they've learned.
I think it'd be great if you're willing to share it.
Oh yeah, that's totally fine. You mean just email it to
Paulette would be great, or Dr. Miller. Thank you.
Yeah.
Thank you for your presentation. It was great. And I'm sure the students love having you as a faculty member.
Thank you.
Like everyone said, you're so jovial. But when you talked about NCLEX, I sit on the NCLEX committee.
Yeah.
So talk to me a little bit about how you're using AI with NCLEX.
So what we do is more learning how to read a next-gen style question. So I'll say, we'll take, and they have to use what's on the education platform, which we use Elsevier, so it's the SurePath AI, and they have to pull from that book. And I teach ARDS. So I'll say, write me an application style. I'll tell them, write an application style question about how to manage a ventilated patient and put it in a matrix style or put it in a SATA. And does that help you? And then I have them reflect, and tell it not to give you the answers, to you to try to figure it out and then give the answers and then reflect on it. And I actually that's what I do for the PN to RN groups, is over the summer, they had to do that, put that in. And I got all kinds of different like matrices and SATAs and drop downs. And they were like, this really helped me to understand how to read a question. Not necessarily that they got it right, but how to understand, to know what to look for. So that's what I found that helps them, because, for our seniors, that's what we want is them. You're not going to know everything, but you need to know what you're looking for, like the details and things like that. So, yeah.
A lot of interest you have sparked. Any other questions, comments? Thank you again for sharing your perspective on AI in nursing. And so, Dr. Milner, if you will introduce our next
Sure.
speaker.
Our next speaker is Dr. Candace Brennan. She is an associate professor at UNC Chapel Hill School of Nursing. She brings nearly a decade of experience in nursing and in leveraging emerging technologies to increase access to healthcare for rural and underserved communities. Dr. Brennan draws on her direct experience developing, training, and evaluating artificial intelligence systems for both healthcare and nursing education. That work informs her contributions to UNC's Artificial Intelligence Committee and to the AI in Education initiatives across the campus. As co-chair of the UNC School of Nursing AI Task Force, she leads development of a strategic plan for AI and future emerging technologies and co-coordinator of the school's AI Special Interest Group. She supports AI literacy and innovation among students, faculty, and staff. Her vision is for nursing education is not to graduate effective users of AI. It is to prepare nurses who lead change in the equitable and ethical use of technology in healthcare. Thank you.
Thank you all for having me. I have the pleasure of listening to everybody go, so it's going to be a lot of that and I also, I think, stand between you and lunch, so I promise to try to keep everything timely. Thank you for that introduction. Thank you for the opportunity to be here and for hosting this. I think these conversations are really important from the nursing perspective, so I'm really grateful that we're all coming together to do this. Again, I'm Candace Brennan. I am an associate professor at UNC School of Nursing and have had some exposure from personal use to just sort of thinking about it from a strategic and curriculum standpoint. So happy to be here with you all today. So I think one of the biggest things that we sort of as an institution thought of when we were thinking about how to prepare students is to sort of pause and think about, what is it that we're really being asked? It's really easy when AI is sort of transforming the world around us to say, we need to transform our curriculum and our program, but is that true? And so one of the things that we've heard today, and I'm going to echo, is that it really doesn't change our scope. And so as long as we stay true to that, this becomes another tool that we just need to learn how to use. So this is not just me, there's a team. And there are three sort of arms to the way that we've approached this. We have sort of our university level. And so we actually just got a new chief of artificial intelligence in the provost's office, Dr. Kairat, who we are lucky enough to have him as a part of the School of Nursing as well. So we have a lot of representation, even at the university level from the School of Nursing. And so we have our internal task force that sort of leads strategy and thinks about incorporation across the curriculum. And then we have what we call our special interest group, which is where a lot of our faculty literacy lives. And also just opportunities for faculty who are interested in this work and those who are at all levels of apprehension, skepticism, and those who are like, yeah, I want to use this in every way I possibly can. So those are the three ways that we support, again, both strategy and thinking about continuing education. A little bit about our program. I think it's helpful to sort of think about the importance of, like, why are we doing this? And so right now we have 342 undergraduate students, 219 graduate students, and approximately 80% of our alumni practice in North Carolina, right? So the biggest piece there is that, that's why this education matters. Those habits that we build the foundation of are going to show up in practice in a year or two. This is something that we continuously ask ourselves. So a lot of the work we do is very equity focused and thinking about not just our students, but our communities. And so we always ask ourselves, does this strengthen safe, ethical, evidence-informed, person-centered care? The answer is yes, then we go to the next stage. But we want to make sure that we're thinking about all of the technology that we incorporate, all the changes that we make that may be AI-based or AI around AI, that we're asking those questions. I gave kind of a little bit of overview of, how we're using it. And again, echoing a lot of what other institutions and even the health system is saying. So learner support, a lot around communication coaching, drafting, critique of AI generated information, so outputs, clinical judgment, huge, right? We've heard that all day. Faculty workflows, thinking about drafting cases, test questions that we're thinking about in terms of practice questions, thinking about NCLEX and how can we align our assessments and test questions so that we're preparing our students to sit for NCLEX. And so using those tools to sort of do that, both as faculty and for our students. And then in research and innovation, thinking about data analysis, but also the output, right? So we have to be careful with how it's analyzing data. Is it, incorporating bias? Is it being holistic? Is it missing something? There is a piece that's required in humans, both the lived experience, but also the ability to say, is this a through line? Is this actually related? And so again, we've heard a lot about human in the loop, but I want to add that and you'll see that in the clinical judgment line, we want human in the loop, but just because there's a human doesn't necessarily mean that we are confirming that they're reviewing the output. And so we talk a lot about the assessment of automation bias, which is sort of like if I use the same AI tool over and over again and it's giving me the correct answer, how likely am I at the end of a shift to just sort of trust it, right? So we want to make sure that we are also assessing for their ability to acknowledge that there can be automation bias. And so we have not tricks, but little assessments that we put in where maybe the output is slightly incorrect or it's incomplete. And their sort of assessment is, do they catch that? And if not, it's a good learning opportunity to say, you really, truly have to assess every output because it has true consequences to outcomes. And again, on the right-hand side, these are just guardrails. So same with other things that you've heard, we have assessment level permissions. So not just can you use it in this course, but what does it look like at each assessment? Can you use it? Do we discourage use because we have some skill that we need you to learn that can sort of be outsourced to AI if we allow use? Disclosure is huge on both sides. Like we've talked about, faculty are using it and we model good sort of habits if we say, yes, we used to make this slides, we use this for this rubric, so we want to make sure that we're practicing the behaviors that we want to see in our students. And then again, we have a closed system. So one of the things that was really important early on from the School of Nursing is that we advocated for a closed system. So we actually have something at the university level called Prompt Lab, which is internally hosted AI models. So they have Claude, they have ChatGPT, they have Copilot. And the importance of that was two pieces. One, we kept that information internal, so it's not training models, which we've heard the importance of that as we think about intellectual property from our faculty and also students and assignments and things that they may be using that we don't want to train models on. But also, again, the equity piece. Not all of our students can afford to pay a subscription for an external tool. And we kind of can create a divide in those who have to use free tools versus those who are paying for like the, top level, top tier tool. And so by offering an internal product, so again, for us as Prompt Lab, they have access to all of those tools as a student and faculty as well. And so we remove that barrier so that we have that equity piece of everybody using the same tools and having access, especially if we're going to ask them to use it. This is just to highlight kind of the ways that we use it both for pre-licensure and in our graduate level programs. A lot of this is going to look familiar. Again, thinking about recognizing fabricated or hallucinated information, to trace claims. Again, we use it a lot in our research course as well to sort of assess the output. So if we have them do, for example, a literature review, they can actually verify sources in the output from the AI. What we see on the graduate level side is we want them to maintain documentation. And part of that is important because as much as we like to believe that we'll always have these AI systems and power and there won't be any natural disaster where we may have to figure out how to do this on paper again, we know that's not realistic. And so we want to make sure that our students retain the ability to sort of function when everything else shuts off. So when your screen goes black, you have to know what to do. And so we want to make sure that they understand that. Again, this doesn't change our license. Our scope of practice is the same. Our standards of care are the same. The competence that we require of our students, documentation, knowing when to delegate something and when not to, that accountability, all of those things are things that we have taught and have had tools that have challenged that over time. And we just reiterate that as we think about AI. And then also the scope of what AI is used for, drafts, predictions, summaries. But again, that nursing judgment remains the checkpoint. So validating before asking, again, knowing when to delegate, and then protect confidentiality. One of the great things about Prompt Lab is that it's improved up to level 2 data, which at first I was like, what does that mean? And so we were very transparent about what can be put in and what we would still say, you don't want to put in. But with our closed system, they are able to sort of put in like student data. So if we wanted to give feedback, we're able to do that without worrying about identification of a student in an external system. And then also escalating unsafe outputs. So we've talked a lot about verifying, but what do we do when there is an output that maybe is demonstrating bias or that maybe is inaccurate? We have to make sure that they understand that they need to raise that concern in the health system, but also to us so we can discuss it. So we've had assignments where we've had some bias outputs from the AI, and we use that as an opportunity to sort of say, okay, when that happens, how do you escalate that? How do you identify that? What are the outcomes, potential outcomes to our patients if this makes it to a patient note that the patient sees? So thinking about that and demonstrating that behavior in our teaching. And again, this is just to sort of highlight the different tiers. We provide this to both our faculty as a part of their literacy training, but also to our students so they understand what's safe and what's not. Again, one of the beauties of having a closed system, we have both Microsoft Copilot that has data protection, but also our Prompt Lab system that, again, accessible to any student or faculty that's not used to train models. We are very explicit that that information is not to be entered into external sort of general purpose tools like ChatGPT, Gemini, etc. We love a good framework. We're nurses. And so one of the things that is very important to us as we think about our approach is, this is actually recent, but it aligns very well with what has been our outlook on AI and the way that we've taught it within the School of Nursing. And if you look at this and you look at all of the domains, these are all of the domains that we would have said we wanted our students to graduate with prior to 2022, right? And so again, it was just a good visual to say nothing has changed in terms of our expectations of our nurses. It's a new tool that we need to teach them how to use within their scope. Again, so looking at sort of how we train and how we assess, one of the biggest pieces for us is moving beyond literacy to competencies. And that's part of what that framework talks about as well. I think we all early on identified that we wanted them to understand these systems and what they did, safe use, what their limitations were, what the opportunities were. But now we're a few years into this and we're a little bit past that. And now how do we demonstrate competencies? And so again, we look for tools and technologies that can help us do that. A lot of it is internal innovation, like we've heard from other institutions as well. We have some wonderful faculty that are very innovative. We don't need to necessarily buy a tool to be able to assess some of these things. So one of the examples is that students receive an AI-generated clinical summary or what maybe AI recommends for patient education. And then they're asked to identify missing cues, unsafe assumptions, things like bias or hallucinations, or anything that may be unclear. So thinking about literacy level, all the things that we want our nurses to be thinking about, we ask them to critique the AI output to do. And then also that's a beautiful way to sort of say, would you want to just sort of export this and immediately have the patient have this? No, right? And so it's a good way for them to sort of see it's a start of a draft, but it's not the complete output that you want either in the chart or going to the patient. And then we also talk a lot about prioritization. So prioritizing assessment based on output, communication, and SBAR. One of the technologies that we did and are currently piloting is around nurse handoff. One of the things, the reason we really love this technology is that it incorporates several pieces of AI that they'll be asked to use that they can incorporate into one activity and with one technology. And so the technology uses ambient listening to listen to nurse-to-nurse handoff and documents what was said. You can export it to the EHR. So we use Epic Playground as sort of our way to train our students on documentation. And then they can tailor the care to patient context. So when we're hearing that ambient listening, it's making that documentation. And one of the things that the technology does is it says, okay, the chart is documented that there's a Foley, but nothing was said in nurse-to-nurse handoff about the assessment of the Foley. Do they still have the Foley? What's next with the Foley? And from that point, then the student can say, okay, I missed this, or was there maybe a social determinant of health that was missed in sort of the automated summary of the documentation that we want to add to the documentation. And then they're asked to verify the output, and then they can decide whether or not to upload it to the chart. The great thing about the technology as well for both the student and faculty is that it's tied to the AACN essentials, the competencies. And so based on their sort of output, uploading of the information, it ties it to those essentials. And so usually when we have them use it in first semester, there's a lot of rid and they freak out, but that's what we expect to see. And then as they go through the program, they continue to use this and they can see those competency change as can we. If there's areas that they're continuing to struggle with, it allows them to tailor education. So maybe, hey, do you want to practice more? And it gives them examples to practice. But it also allows us to see, do we need to think about individual interventions with our students to get them all where they need to be by the time they reach the end of our program? So I'm from our institution only, so I want to make sure that I'm clear here. Here are some things that we've noticed as trends, opportunities, and gaps. Clinical adoption is outpacing formal instruction. I was back there furiously taking notes as I was hearing how it's being used or what pilots are happening in the clinical space, because we often hear in venues like this or from our students what's being used. And then we can think about, again, not adopting the technology one for one, but how can we teach them how to effectively use those technologies? And again, within the domains of nursing. And then curricular emphasis on expanding beyond just academic integrity, again, towards clinical verification and confirming those competencies. So just knowing that it exists and how it exists, at this point, I think we can all agree is we need more than that. So we need them to demonstrate that they can safely use these tools. And then for us, opportunities, simulation has been by far the biggest place where we've seen the opportunity to allow for practice of a lot of these skills. But as a midwife, I'm going to say that human aspect of it is very, very important. And so we see simulation as sort of the dress rehearsal for human interaction. You cannot, I don't care if there's an avatar, replace what it means to see a smiling face or to make eye contact. Like that hormonal cascade that happens still has to happen because our nurses are still going to touch real people. So that's very important to us to use that as additional practice to reinforce the things that we want them to exhibit when they get into their practice. And then vetted institutional environments really make safe and equitable practice. That's really important to us. And we also want to make sure that we're not passing on those costs to the students. And so we're very intentional about what can we use our innovation and scrappiness to create internally, but also just being mindful as we're bringing in new technologies. Gaps, so faculty readiness has and still is uneven, and we're working very diligently as we think about literacy to incorporate ongoing continuing education. But we also understand that we're not all going to be at the same place ever. There'll still be people who very much value certain aspects of teaching that don't incorporate AI. A lot of us weren't trained on this, so a lot of us were learning in real time. But we do feel like it's important to make sure that we supply the resources as people need or would like to have them to train. And then emerging education frameworks, the framework that I pulled, that I showed was one of the ones that is one of the newer ones. But again, we're still, I think, as a profession looking for more competency standards and nursing programs. And as much as we can have standardization across those recommendations. And then a gap is thinking about de-skilling and automation bias. They're real. And so they require continuing education, not just for our faculty and our students, but also in the practice setting. And we should be measuring that, right? I think it's very clear if we look at documentations and chart audits in practice, when someone may have just sort of verified an output that needed a human touch. And so it's important internally that we're measuring that in education so that we can highlight how important that really is in practice, but also as people are transitioning to practice to continue to remind them of that importance as they get competing priorities in that transition to practice. All right, hopefully I talked fast enough. Thank you. Happy to take any questions.
Thank you so much, Dr. Brennan. Are there questions, comments for Dr. Brennan? Yes, Dr. Tillman.
Thank you for that wonderful presentation. And I really love that you mentioned blackout. Like, okay, we're teaching students all this and, how about if, like you said, a blackout? Will they have those basic knowledge and skills to certainly write and carry on? But I kind of equate it to a map. I'm old enough that when I grew up, we had to read a map. We had to see what the position of the sun. My kids, on the other hand, totally rely on GPS. And so it's like, if something were to happen, you guys would not know exactly where you're going. And so I think that's great that you mentioned it, because it is certainly something that you have to be mindful of. It's great technology. We want to embrace it and move forward, but also think about, yes, how about if there's ever a time that we don't have that available? So thank you. Mhm.
Yeah, that's one of the simulations we do is like they go in and they think they're gonna use their EHR, and then we say, oh, it's not working, it's down. What are you gonna do, right? So, you mentioned maps. I'm in your children's generation, and I would probably just have to pull over and wait until so I'm guilty of that myself.
That's okay. Any other? Yes.
I love your discussion of the automation bias and how you teach the students that, there's an output, but I need to critically analyze that output every single time. And just because the alarm is beeping doesn't mean that something is going on, and it doesn't mean that something is okay. You still have to look at it to make sure. So back to looking at that patient to see if they're okay and what they may need. So thank you for bringing the automation bias in.
And I ditto that comment. I had automation bias written here as well. And I did want to ask about, I want to thank you for sharing that framework. It was wonderful. I have that in my notes so that I can go to that as well. But on, I think it was slide number 5, you had a comment about teaching pre-licensure students to respond to patients and families arriving with AI-generated information. Could you just elaborate on that a little bit?
Yes, that's like a side passion of mine and a soapbox I get on, because one of the things is we are sort of the gatekeepers of trust, right? Like we are the most trusted profession, and that's wonderful to hear, but it comes with great responsibility. And so one of the things that we work with our students a lot is communication around communicating evidence, right? So when they show up, if someone shows up with something from, AI or social media, right? Because that was sort of before AI, that was the thing that we sort of discussed around that communication. And so we discuss a lot about keeping that respect and how do you communicate where you are communicating evidence but maintaining trust. And so we do a lot of discussion in the class and exercises there, but also as a part of simulation as well. So when we're doing therapeutic communication, one of the things that we bring in is misinformation. So we'll have a patient that, maybe a standardized patient that comes in and has a deeply held belief that's rooted in misinformation from something they received. What used to be, we say on social media, and now we say was an output from AI. And so again, part of the literacy is them saying, general purpose AI tools are pulling from all of the available internet all of the available information on the internet. Some of that was wrong. And so it's very possible that an AI system can output something that is incorrect. And so we teach that, and then we say, you don't want to say that to a patient because you don't want to create a barrier between you and that relationship. So how are you going to communicate that? And so that's really an area where we have them practice therapeutic communication in conveying evidence, but preserving that trust relationship of the patient-nurse relationship.
Awesome, awesome. Any other comments? I hope my team is listening back home because that was great. So I just thank you again, Dr. Brennan, for your time and your perspective on AI in nursing. I want to thank you, Dr. Milner, for providing information related to this topic, and thank all of your presenters, Dr. Draper, Ms. Goodall, and again, Dr. Brenner, for your time today and for sharing your expertise as the Education and Practice Committee continues to move forward with this very important charge. At this time, we will take a break, a lunch break for, let's say we come back, it's 12:13, and so we will resume around 1 o'clock. Thank you. The Education and Practice Committee meeting is now back in session. We are on agenda item 7, I believe. Let's see. Yes, 7C, investigations. And so now I will turn to investigations for information related to AI in nursing regulation. And I'd like to ask the Director of Investigations, Dr. Dr. Ann Hardy, to present her 2 case studies. Dr. Hardy.
Thank you, Dr. Ingram. To date, we have not encountered any cases in which an allegation or explanation has involved the use of AI. However, as AI becomes increasingly integrated into healthcare documentation and education, we anticipate that its use may become a factor in future complaints and investigations. Based on the Nursing Practice Act and the North Carolina Administrative Code, the nurse remains ultimately responsible for the care provided and documentation of that care. This approach is already established and applied in the investigative process and would similarly apply to the use of AI-assisted tools. The adoption of AI within healthcare facilities will not alter our investigative process, the manner in which we evaluate evidence, or our decision-making framework. A typical investigative process includes interviewing witnesses, reviewing pertinent documentation, such as patient records, internal investigations, witness statements, facility policies, and previous disciplinary actions. Once an investigator has gathered as much evidence as possible, the licensee is interviewed and given the opportunity to respond to the allegations and answer any questions regarding the evidence that was collected. One consideration will be the variation in AI-related policies and procedures across healthcare settings. At times, an investigator will request a facility policy related to the incident described in the complaint. This is informational and can be used to educate the licensee during an investigation, such as what could have been done differently, what should have been done, or does the facility policy procedure support their actions? An example would be a large hospital system and a long-term care facility may have significantly different approaches to AI use. For this reason, our process will remain case-specific rather than creating universal expectations across healthcare settings. Not having an example from our caseloads, I've created 2 hypothetical situations that we could see that would involve AI. The first would be a nurse entering patient information into an AI platform that is not approved by their facility in order to generate patient education or discharge documentation. This type of activity raises concerns related to confidentiality and documentation. More specifically, potential violations of the Practice Act include obtaining, accessing, or revealing healthcare information from a client record or other source, except as required by professional duties or authorized by law, and failing to maintain an accurate record of all pertinent healthcare information if the nurse documents AI-generated information into that patient record. A second situation might include a nurse using hospital-approved AI platforms to generate clinical documentation and signs the note without reviewing its content. If the documentation contains inaccuracies, the nurse will remain responsible for the accuracy of the record. Similarly, the situation raises the potential documentation violation of failing to maintain an accurate record of all pertinent healthcare information and failing to review the record prior to signing it and ensuring its accuracy may significantly impact continuity of patient care and may lead to an allegation of falsifying documentation. I'm happy to answer any questions.
Thank you, Dr. Hardy. Are there questions for Dr. Hardy from the committee? Seeing none, what about staff? Any questions for Dr. Hardy? Okay, just a comment. I thought about when you were sharing the case studies, the potential.
Yes.
When we're busy, and using AI, information is there, on to the next one, and we hit submit without reading. I'm certain that it happens. This is not a resolution,
Right.
but just a comment. I can really see how that could happen. So I'm hoping that there are mechanisms, and I'm sure there will be, if not already, in terms of, did you review this, if it's accurate? But even still then, click, right, and submit.
It will be interesting. And the speakers brought up a lot of good points, and one Meredith asked specifically as far as auditing, which we do have that ability now to look at records for auditing of documentation when it was documented versus when it was documented as being performed. So I think this will add a whole new layer to being able to audit records, but that is also an ability we have that varies from facility to facility. A long-term care facility is not going to be able to audit everything that was put in where a larger facility would. So luckily, it's a process we're already used to looking at, but I
Yes.
do think it will add a different layer to the cases.
Yes. All right. Well, thank you so much. Oh, okay, yes.
Thank you, Madam Chair, and thank you, Dr. Hardy. I was going to say in real time, as I've gotten back into practice, I love that example because I have seen that already, and it's been interesting to me seeing both sides of this and reading cases and being involved. I think just like your example, where we used to not have enough clinical rationale, like it was almost you didn't give enough as to why you made this decision that may not be, or deviate, it could have deviated from guidelines. Now I'm seeing AI is supplementing in a way that you're getting more information, but it's not accurate. And where I think it gets more complicated, just in my anecdotal experiences so far, has been in the wonderful tool of streaming a hospital course and telling you why the patient came there, what happened while they were there, previous diagnosis, referrals that were brought in. But sometimes it hallucinates diseases that never were diagnosed. It'll take suspected differentials and make it as if that patient has diseases. And what makes it even more complicated is that the carryover, like the templates, we used to be like, if you didn't do that exam, don't carry over the exam from 2 weeks ago or 2 years ago. Now it's historical. Same thing, carrying over information that may not have been vetted correctly. You're doing your best. You trust the clinician that was before you or the referral specialist that wrote the note for guidance. Now you have the complication of layers of what's real. And it just brings back don't trust all the information you see and know that your colleagues are using AI and may not be as informed. And now you've got that carryover complication on top of seemed real. So the communication with the patient is also really important,
That information will impact the way we do our interviews, similar to way some of the educators were talking about asking the students, tell me how you got to that point or explain how you got this answer. When we're looking at records, it's already routine for us to educate and explain and talk about standard of care. So if we have a record with a whole lot of clinical rationale and within the interview, there's not an explanation for how they got to that rationale, I think that would be, again, something we already do, but would take a different layer with AI.
Excellent. Any to Dr. Shaw? Yes.
Yeah, I mean, I have a comment, and I'm trying to give you the real world too that I see. And, a lot of AI tools that we have and platforms, it's interdisciplinary. So it's not just the nurse using this one tool, it's other people, to your point, are using the tool. So, for example, I can be a nurse in a care setting, and the physician is the one that determines the diagnosis for the patient. And then AI tools may auto-generate patient education to the patient portal, to another platform for the patient. Who is accountable for the patient education in that setting when it's going from, the physician is the one that determines the diagnosis, the AI generates the education. I'm just giving an example that then goes to perhaps a patient record for them. That's their education. Yeah, that's my patient as a nurse. Am I accountable if, for some reason they said they didn't get that education or nobody reinforced that? Like, so I think when these are going to be cases that will come before us. How do we, when we're doing those investigative processes, how do we also think about the others that are part of the care of the patient. I mean, I think it has implications on the outcome of those cases. And to me, it's kind of hard to determine, because nothing's black and white sometimes. So I just, I mean, I think those are just some of those things that implications to these great tools that we have that we don't always know the answers to, and then how to deal with those, processes if in the event they were brought to the board. So
It's very, very true, and we will be learning it as we go. But luckily, that's already part of the process is to talk to the witnesses and who else is taking care of that patient. And I mean, each case is individually looked at. So but they're all good questions. Yeah, they'll all come up, I'm sure.
Which for me just reiterates the point that we need to be at the table during these discussions for purposes such as the example that you just shared, Dr. Shaw. Otherwise, things would be developed without us in mind, without our scope of practice in mind, and could lead us to some places that we should not go or we don't want to go. Yeah. All right. Any other? All right. Well, thank you so much, Dr. Hardy. I appreciate your case studies, and I will now turn this over to our Chief Legal Officer, Mrs. Meredith Paris, to provide the committee with a review of the laws and rules regarding AI in nursing.
Thank you, Dr. Ingram. So I want to start off, I'm not going to do a disclaimer, but what I do want to share kind of a little anecdote about AI use, and it's perfect for this topic. So when I started, to Dr. Tillman's point about we can read a map, when I started law school, my very first year, you had books and you went to the library and you had you had to follow the trail. You had to look for cases, you had to look for statutes, and you couldn't just go to the internet to look at it because it was forbidden, right? And I certainly wasn't going to get myself in academic trouble. And, there were cases of people hiding books, and it was highly, highly competitive. I want you to know that I booked that class. I was the highest scorer in that class. So when you want to talk about research, I'm your girl. Now, I'm a dinosaur. Admittedly, I love my paper. I've taken notes throughout this meeting. Everyone understands that. And I work with an attorney who came along in the internet age, and she is pulling me along. And so when I first heard about AI and regulation, and we discussed it actually at the ICRS graduation leadership course in 2024. We discussed it, and Phil Dickinson was there. And, I stood up and asked him because he's all excited about some AI. I don't know if you've attended some of the sessions that he's had. So he's all excited about AI. And I'm like, oh my gosh, this is like me and marijuana, right? This is going to be a regulatory nightmare. How do you regulate something like this? Medical usage, non-medical usage, what level of usage, what impairment level? Anyways, I digress. But me being me, stood up and I said, this is great. I love that you love this tool, that you're embracing it. I don't embrace it. What are we going to do about nursing regulation? And he looked at me and said, we don't need to do anything. It's a tool. It is a tool, and it does not take away clinical judgment. And so that is what I want the board, this committee, to take away from is we already have it. We have it in place. He said that to me and a light bulb went off. He's a highly intelligent man. He's now the president of NCSBN. CEO of NCSBN, and came from an education standpoint, so he knows what he's talking about. But I think the research that you've been provided today from every single department is very thorough, and it always comes back to human judgment and human accountability. And you heard human in the loop constantly, and I think it was Dr. Brennan that said it's an active human in the loop. And I think that goes to Dr. Shaw, your point. We're not just going to click and check yes. Who's going to be accountable? And you need that human accountability. Every presenter said human in the loop, or human role and human connection. Human judgment is essential. It's about accountability. It's a starting point, meaning AI. And Dr. Brennan echoed that of our CEO of NCSBN, is that AI is just a tool. There is no need to rush out and change the way we do things. In her example, it was, we don't need to change our syllabus. Let's hold on. Let's put the brakes on this. So I do want to piggyback on all of the education information that you've been provided today. Is we don't need to rush out and make some big sweeping declaration. And you're going to see that in all this research I did from a legal perspective, law hadn't caught up yet. And, in order for us to take some sort of action or make a rule, you have to have the statute. So going back to me being a research nerd, I'm very proud of that, by the way. It's the only book award that I got, but stand by it. I love research and I love digging for that. It is not second nature for me to do this on the internet still, right? But it's important. So I looked through the North Carolina statutes and, scoured the, MPA, the rules, obviously knew ours, wasn't going to be there. But what about the Medical Practice Act? Let me see what they have. Nada. What about other occupational licensing boards? I don't see anything in law, right? We've been monitoring bills, part of our legislative overview with Dr. Griffiths and Angie Mathis, looking through these things with, that lens in mind. Even if it's not nursing specific, are there other laws or potential bills that are introduced that will affect ultimately other occupational licensing boards? And in North Carolina, the landscape is bare, but that's not inconsistent. That is consistent across the nation, across other jurisdictions. And so there are no statutes in North Carolina that address the use of AI in healthcare delivery. None. So going back to, the other little story I want to tell is research, right? So I'm like, Alexis Trimble is also wicked smart and knows her stuff. And she is of a younger generation where she has said, I love AI and I think you should use it more. And, I'm still like, you got to drag me along on this because it's not in my nature to say, I feel like it's cheating, right? This has opened my eye about how it can be a very useful tool. So as an attorney, what I do when I can't find anything using my own little research and my own tools, I go to I'm not going to say the site, right? 'Cause here, legal liability, I'm not going to say the site, but I go to one of the premier legal resource online uses. I'm not even gonna go, yeah. So anyways, they have an AI. They have an AI system. It's really hard for me not to say what it is because that's how I think about it. But they have an AI tool and it's a new tool that, with Alexis's urging, I went to Dr. Tillman and I said, she is all about this. I've done 2 trainings now on it. I'm open to the possibility of using it. It might be a time saver. I've got someone who's younger than I am that can actually teach me how to use it and benefit from it. Plus, I want to stay on the pulse of what's happening nationally, and it does talk about bills that are introduced. So I put in AI in healthcare in the search engine, and I started out specific to North Carolina. And do you know, they gave me a statute that said this is all about AI in North Carolina. This is a law in North Carolina that addresses AI. I'm like, oh, this is great. Writing it down, printing it out. Let's go further. And so I went down the chain. And so after I got all of that, and I said, well, let's go back and look at it, right? Human accountability. That did not say anything about artificial intelligence in law. It talked about automatic driving, automatic vehicles, right? It's not there. Interestingly enough, when I went back through again and did not use AI, and I went back to my other resources, and so then I went outside. I said, well, what else would use AI? We have in criminal law, what constitute an image is now included as images are those that are created with AI, right? This is huge. But that's the only place in our statutes that references AI specifically and includes it in a definition. And I think that tells you, and I always say, the law's never going to keep up with technology, right? But they're trying, and the definition for AI that was incorporated in criminal law was in 2024. So that still tells you that this is not developing fast enough, because I can tell you that there are tons of digital images out there, and quite frankly, as a former prosecutor, I don't care if it was created as a digital image in the likeness of a child. It is a child whether you look at it or not. And that's what the law now says, right? So I think that the um, legislative representatives, Senate representatives, I think that they are cognizant of what they want to do with AI. I think this is something that they are being very intentional about, because it's not just getting thrown out there. And I think it reinforces what Dr. Brennan said about, like, everybody wants to jump on this new tool, but let's wait a minute and let's see, how is it really going to work? Because we don't want to create bad law. That's what we say all the time when we're talking about moving forward with cases. So all that to say, North Carolina is not any different than any of the other states, right? Now, Angie's going to talk a little bit more about position statements and what she found, and I think Dr. Griffith's going to do the same thing. When I was doing this research as well, it talked about the Department of Insurance, and they just have basically a guidance document for insurance. And again, it goes to insurance. And I think that's consistent with what you're going to see federally in terms of regulation. We're not to the actual professions that are using AI or dictating how they use AI. What the federal regulations, because again, I searched North Carolina and then I expanded it nationally and other jurisdictions. And then I'm like, well, let's look at federal law too. I was prompted by Dr. Griffith. Thank you very much. But, that it's good to look at. It's necessary because eventually there's going to be a trend towards the states. And federally, they are still, I don't want to say behind, but they're behind. Because they're still looking at who is developing these AI tools. That's who we want to regulate. Do they have safeguards in place as to, if PHI is put in, what's going to happen to that? How does that, keep itself out there on the internet? What is AI doing with that information? And so they're looking at federally, the developers of these programs. Insurance is mentioned a lot as well. When it comes to a diagnosis and how the insurance agencies are using it, and insurance companies. It talks about medical devices and AI and the use of medical devices. And it is more on, there is an exception in there that makes it clear in the definition of a medical device that human judgment and analysis are required and applies to those healthcare professionals using AI. So even the federal government is saying, we're not going to put much out there, but what we're going to say is it goes back to analysis and human judgment. And I think that's consistent with what Phil told me in 2024, what you're hearing today, what you've heard from the speakers, what you've heard from staff. Colorado did introduce a law, and it became effective on June 30th of this year. And their regulation, surprise, surprise, focuses on the developers of these systems. So the law's not there yet. It just doesn't exist. I will say, under all of these things, I found one. So, right, needle in a haystack. I found one regulation from New Mexico that specifically speaks to artificial intelligence. And it's for APRNs exclusively. And it says what you're hearing today. And even the same language, decision support tool, augment. There's still clinical reasoning and judgment, and it can't replace those things, right? I think that when you heard from the educators and how they're building this into their programs, they recognize, and I think, the board recognizes, this is going to be something that, unlike my dinosaur self, we got to catch up on. And we have to be aware of it, and we have to be aware that it's going to be used. So let's start with the foundation of these students, right? when I was in law school, it flipped and you started being able to do electronic research. So 4 years after I graduated, they weren't using the books anymore, except to look pretty. They were still, they switched. They said, let's do it. And they actually piggybacked off of 2 legal research developers for the internet. And so they said, we're going to do it with this system and we're going to do it with this system and you guys can compare. So we're all moving forward in this age of technology. AI is it's a resource and it's a research tool. And New Mexico put it in their administrative code. And that doesn't really need to be said because that's where we're at. And I think that's where everybody's headed. So it was encouraging to hear that when the APRN has to demonstrate a basic understanding and an awareness that there may be an inherent bias, I think that getting that at the educational level is what is key. And kudos to these programs that are moving forward and doing that, because that's their role, is to teach them what this will look like in nursing practice. Going to, and I'm going to piggyback on Anne's presentation a little bit. We talked about cases and case examples, and Angie, as the former director, we talked about it too. Like, can we think of anything? And we haven't seen it yet. But what do we see? And she did the hypothetical that we see all the time: pre-documentation, right? That's not really that different from AI. We're carrying forward a note, like, oh, this is what happened 2 days ago. So I'm going to carry that forward, and then my shift, I'm going to go change it. That's still not good nursing practice. That's a violation of the Nursing Practice Act and the rules, because you're not taking appropriate documentation. You're not taking the time to input your own clinical judgment, your assessment from January 1st when something happened on December 30th. And that's when you fall back on, what does our NPA and our administrative code say? And we have the mechanism to regulate the use of AI in nursing practice. And I also want to address, Dr. Shaw, you're, piggybacking on who's going to be accountable in these situations. Let's take a step back from that and look at this as, what's your role as a nurse, right? If a doctor gives you an order and it's not consistent, or, say, non-nursing, so give me a little grace here, but let's talk about orders for insulin, right? If you've got a patient who's presenting like they are experiencing ketoacidosis or whatever, and I know, woo! That's right. Thank you. That's right. DKA, right? So let's say, and you have a protocol, because we all know that the protocols exist, and for good reason, because you're not going to be able to get that provider on the phone every time. But let's say that they are giving an order, and in your experience, what they are ordering isn't even going to touch it, right? What are you going to do? You're going to advocate for your patient. You are going to go back and challenge that order and say, I hear you, but these are the symptoms that you're not addressing. This is the assessment, and you're going to say it in a much nicer way, I'm sure. But it it might depend on the situation. But let's say that you have a patient. I'm going to use a different example, and I'm not going to be able to use big words. Sorry. But let's say you have a patient who is a fall risk, and you want to give them something that is truly going to like a super big blood thinner or something, and they're getting ready to go into surgery or whatnot, and this is not what they meant to give, and this is not what was meant to be given. And so you want to reach back out and say, did you see this? They're allergic to this, or we have those tools in place. And it's the nurse, when you are implementing these orders, you have to use your own judgment and your own clinical analysis. And so you will be held accountable. Now, I'm going to go back to, We already have these things in place to address them, right? We have, the board has adopted protocols that build in a just culture model and address the situations where you have a new nurse who might not have that expertise and experience to say, yeah, that's not right. Or they might feel like it's not right, but haven't developed the confidence in their role to say, I can't challenge the provider that wrote this order. Well, we have those built into our protocols. We have mitigating and aggravating factors. These are all things that staff and the board has permitted staff to consider and wants us to consider in a just culture model. So while the nurse is going to be held accountable, we as a board are also addressing, is this a case for remediation? Is there a pattern? What are the specific circumstances? Is it a systems issue? Does everybody pre-document? Are there resources? These are things that we're all looking at. And it comes back to, and I will say it again, we have the tools already. We have the law, we have the rules. Those talk about what the nurse is required to do, and that is what they are accountable for. However it gets you there may be an issue. It might work 1 or 2 times. Practice drift, that's another thing. We know it happens. It might be fine for this nurse to do it 1 or 2 times, but they do it 10 times and it starts to become a habit, and it's not a good habit. And that's kind of what gets you into trouble because you're not going back to your Nursing Practice Act. And so that's your accountability. We have the law, we have the rules that speak to what AI does in everyday nursing practice. It might not say it, but it talks about accountability. It talks about components of practice. It talks about scope. And we have the violations that would take into account, was AI used? And how is this nurse in this situation accountable for that use? Right? So I think that that's a good thing, Dr. Shaw, because that's something that we will be teasing out. I think also too, to Dr. Hardy's point, we already do these things in investigations. We're already pulling audits. Dr. Lytle's presentation, I was clear on what I was asking because I know that's what the investigators are doing. They're able to pull an audit trail. They're able to see if a nurse is click, 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 and not filling in those blanks or, falsification. They click, yeah, I did all these things. And then you hear the patient's not even home for a home health visit. So that's an extreme one, but we see those things. Those are everyday violations of the Nursing Practice Act. And I don't think that AI is going to replace what those violations are. It's not going to, because we already have the cushion around it. But what we do need to do, and I think you heard this as well from the survey that Dr. Griffith went over, is they want training. And it's not our job to train the nurse, because our job and our focus is protection of the public. So when we discuss, and when you all discuss the research and the information and go forward into discussions, I want you to look at it through the lens of public protection. And what can we do? We don't have a law that would support a rule. So we really can't engage in rulemaking with this situation. There's just no way for us to do this. So what is our role, right? And I think that you're going to hear from Ms. Mathis about the position statement that has been drafted. And it was actually reaffirming to see from the other presentations, these are the things that we'd like to see and we support. We've ticked off a lot of those boxes, if not all of them already, in the position statement. But I think that is something, if you were to ask my legal guidance, which hopefully you will, is that a position statement can be that resource for the nurse. Ultimately, what do we say? It's going to be their employer to make sure that they are competent to be doing these things. It's going to be on the employer to define the protocols. And I think it was Mr. Wall who said, This is not a scope issue because if with a policy, you can narrow the scope, but you can't expand it. And it's the same thing with AI. You can narrow that scope with the use of AI, but you're not expanding it. And I think it goes back to what is the nurse responsible for? And that's their competencies, using their clinical judgment. And you can provide guidance, just like we provided guidance in other situations, in IV hydration therapy, other situations, thinking of other position statements. And of course, they're coming to blank right now. But this is no different than let me provide guidance in this certain area. And I would encourage you to look at all of the things that you've heard. The survey, like you said, Dr. Ingram, that's a huge response in a short amount of time. And I think it really honed in on the nurses out there, by and large, understand what their role is in the use of AI. It's a tool. It doesn't replace clinical judgment. It augments clinical judgment. What they want is clear policies from employers, which we can't give them. But they want education and training, and a position statement will provide that quick resource, that guidance for them to say, you know what, this is a tool and I need to use it responsibly, but this doesn't mean it's right. But I think one of my favorite quotes is Abraham Lincoln put that on the internet, right? So it took y'all a minute, it did, but it's a good point, right? So my suggestion and guidance for this board is consistent with what we've seen across the nation, which is a position statement's going to address this. There's not a legal landscape yet, and there may be in 5 years, but we can't get ahead of ourselves in that situation and try to create a rule when we don't have the legal framework to support it. I'm happy to answer any questions you may have.
Any questions for Meredith? Meredith, we will definitely continue to seek your legal guidance. Absolutely.
I certainly appreciate that.
Yeah, absolutely, we will. All right, well, if there are not any questions or comments for Meredith, I will now turn it over to Dr. Griffith to provide the committee with an overview of the National Nursing Organization position statements.
Thank you, Madam Chair. So in reviewing the National Nursing Organization position statements, I reviewed 8 different position statements. And I don't want to rehash everything that was stated today, but really these position statements reiterate everything that we've heard today about accountability, not losing that nursing interaction with the patient, that human touch. So the themes that were identified is AI as a support tool. We've heard that over and over again today. It's not going to replace nurses, but it's a tool that nurses can utilize in their practice to help support that patient care. Education is needed. Workforce needs to be ready for this. It sounds like our programs across the state are starting to implement education on utilizing AI tools within the program, and then preparing them for their next step into nursing practice. There are patient safety issues and risk management issues. It'll come to an investigation when there is a concern related to the documentation maybe not being accurate. There's issues with continuity of care because what is documented in the medical record. Then we talked a little bit about bias and equity and fairness in the use of AI. And we're going to rely on our healthcare agencies to ensure that the tools that they're putting in place are supporting that bias is removed from their AI tools. And if not removed, then the nurses can identify that there is an issue there with the information that's being outputted from those AI tools. And then privacy, security, and confidentiality are at the forefront of our thoughts related to ensuring that the information that is entered into these AI tools are remaining confidential so that patients' private healthcare information is not being shared in the deep, dark web of where this information may go and where individuals may utilize this information to sell and make money off of. And the last thing is that nurse involvement in AI development within their healthcare agency and the implementation of those AI tools within their healthcare environment. And as Meredith talked a little bit about the position statement, what I was thinking in regards to the position statement that Angie's going to be presenting shortly is it is a tool that nurses, I think, can use to take to their healthcare agencies, employers, and say, this is the guidance that I've received from my regulatory body here in North Carolina. Can we engage in some conversations around how nurses are involved in this process? I want education on how I can utilize AI tools in my clinical practice. So I think the position statement will engage nurses to be able to start having those conversations with their employees if they have not had those conversations yet. That will conclude my report.
Thank you so much, Dr. Griffith. Are there questions or comments for Dr. Griffith? And committee, as a reminder, that's agenda item Roman numeral 9 that Dr. Griffith was referring to, if you want to refer back to that. So seeing no questions or comments for Dr. Griffith, thank you so much.
I have
I'm
one
so sorry.
staff comment.
Yes, Mary.
Because it occurred to me as these presentations were coming forward, and Dr. Griffith, as you were presenting, like, this is a tool, right? I think also it sends a message to these employers that you need policies in place and you are responsible for the education and training. And so the board, by putting that statement out there, it's not only a resource for the nurse in that specific situation, but it also sends that message to employers that this is your responsibility too. The education programs are doing their part, but think about this. And I think some, we heard from ECU Health, UNC, but they are doing this, but I think this sends a message to the smaller employers that might not have the resources that Duke would have, for instance. Thank you.
Thank you, Meredith. And so no additional comments or questions. I will like to ask that Senior Policy and Data Officer, Mrs. Angie Mathis, provide the committee with an overview of the existing occupational licensing board position and advisory statements.
Thank you, Madam Chair. So in reviewing other nursing regulatory boards for existing position statements, opinions, or guidance documents, only 2 NRBs, nursing regulatory boards, out of over 40 that we reviewed, have published formal guidance. So much like Meredith was saying, there's not in terms of law and like legislation throughout the country, there's also not a lot of formal position guidance has been published from regulatory boards. Reference materials are in your packet from both the Texas Board of Nursing and the Colorado Department of Regulatory Agencies, I'll refer to as DORA, are included in your meeting materials. Additionally, we looked at various North Carolina occupational licensing boards to determine if any have formal position guidelines regarding the use of AI. Only 3 have published formal separate guidance directives. The North Carolina Bar, the North Carolina Real Estate Commission published a bulletin article with an opinion, and the North Carolina Board of Examiners for Engineers and Surveyors. And these are also included in your meeting materials. The North Carolina Medical Board's position statement on documentation did contain 1 or 2 sentences cautioning their licensees about the use of AI with respect to documentation. The Real Estate Commission guidance mentions privacy, transparency, and reminds licensees to ensure that their practices are in alignment with law, rules, and ethical standards. The Engineer and Surveyor Board guidance states the licensee must be directly involved and maintain control of all aspects of the work. The North Carolina Bar stresses independent judgment is still the responsibility of the licensee. Meredith, you listen. And all work products and association implications from the use of AI, the licensee is held responsible for. So nothing in this is any different than what we've heard throughout the presentations and the review of literature thus far today. The Texas Board of Nursing adopted a position statement in 2024 and revised it earlier this year. Key aspects of the Texas guidance include AI's complementary and supportive role and not a replacement for nursing skills or judgment. We've heard that just a few times today already. Professional responsibility for understanding the AI tools being used and ensuring validity and reliability. That's the responsibility of the licensee. It also points to existing standards and regulations for patient safety, confidentiality, and data privacy, anti-discrimination, patient education, collaboration, and continued competency. Moving on to the Colorado DORA guidance, they acknowledge the rapid development and use in healthcare, pointing out some advantages potentially, including efficiency and reduction of administrative burdens, but also mentions the unknown and potentially detrimental impacts on patient care if used inappropriately. During their development of the recommendations, they reviewed various bills introduced throughout the country. Key aspects of the Colorado recommendations included that AI does not use discriminatory algorithms. Protection of privacy is essential. Decisions regarding patient care and treatment where AI was used must be reviewed by the licensed professional within their scope of practice. It is an assistive tool and should never replace the professional. Professionals should have the ability to override the decisions generated by AI. Patients should be informed about the use of AI in their care. Impact evaluations and studies should be done by the deployers of AI, which would be the organizations that develop these tools, and that any use of AI should align with existing regulations to ensure data privacy and protection. Both Texas and Colorado statements have some common themes, which we also saw in our survey responses. Concerns about privacy, security, accuracy, and AI being used more to augment or supplement, but never to replace professional clinical judgment and decision-making. Based on our survey results, about a third of the respondents reported using AI, which underscores the importance of providing some guidance to our licensees. As we have seen in review of other regulatory agencies, technology and use has accelerated more rapidly than laws, and we heard that from Meredith's presentation as well. Laws and rules and formal guidance have come much more slowly. To talk about the position statement now, it does not carry the force of law or rule, and thus it only seeks to add some clarification and guidance to our regulated licensees. The Nursing Practice Act and our North Carolina Administrative Code, that is what provides our guidance and is not to direct or be prescriptive for the use of particular AI tools, but rather to bring focus and clarity on some particular aspects of AI use that are pertinent to nursing practice and which lie within our authority. As we've heard today from our survey responses, presentations, literature review, and reviews of existing guidance, both on the national and state levels, the use of AI in healthcare and more specifically in nursing is evolving constantly. The proposed position statement seeks to provide additional guidance for our nurses when utilizing AI tools and to point out particular aspects of AI use in nursing of which nurses should be aware. And as our speakers were presenting today, I took the draft position statement that staff has proposed, and I just highlighted things that I kept hearing throughout the day. And so I'm just going to kind of read a few of the highlighted things that I have made note of today as we heard the presentations. It's a tool. It's not a replacement for nursing care, judgment, or decision-making. We've heard privacy, security, transparency, accuracy, ethical and responsible use mentioned today. We've heard the term supportive tool, that it doesn't replace. We've heard maintain competence for understanding the use of AI, professional responsibility. AI, information generated by AI must be reviewed and validated. There's that human loop that we've heard today. It's support, it does not replace. Professional responsibility, inaccurate, biased, relevance and appropriateness for patients' clinical situations. So nurses are responsible to ensure that they are not using inaccurate or biased information to deliver their nursing care. And then the last word I highlighted today was verifying. Again, the human loop, that nurses are responsible for verifying the accuracy and appropriateness of the information generated by AI. At this time, Madam Chair, board staff recommendation is that the Education and Practice Committee approve the position statement recommendation entitled Use of Artificial Intelligence in Nursing Practice and direct it to the full board in October. And I will point out that I see two spacing issues where the spaces need to be corrected, probably from going back and forth on SharePoint web-based and Word-based. So
Thank you, Ms. Mathis. And so are there any questions for Ms. Mathis, first of all, related to the overview of the existing occupational licensing board position and advisory statements that she provided? Okay, so seeing none, now is the time for us to discuss the information that's been provided and the drafted position statement. Is there any further discussion on this matter, committee members? Yes, Dr. Kistler.
I just have two comments. I do know that the conversation around bias has constantly been acknowledged today, and it is mentioned at the end of our statement. But I might recommend that under the AI tools where the North Carolina Board of Nursing recognizes the AI tool, that we may put some language there that addresses that we acknowledge that there may be inherent bias and that there's a responsibility by the nurse. The other component that I just would like to make recommendation for is regarding the definition we chose to use. It states that artificial intelligence can be defined as computer systems that can perform tasks with human-like intelligence, such as understanding language, recognizing images, learning from data, reasoning, and making decisions. The term reasoning in this definition is inconsistent with AACN's 2025 page 5 reference that we talked about, where it says AI does not provide reasoning. So are we in conflict a little bit in those things? And is there a better definition that we could use that would not be inconsistent with the terms where we're trying to say augment our clinical decision-making and maintain reasoning? So is there an opportunity to potentially use a different definition in this space? Thank you.
Thank you, Dr. Kistler. So board staff are taking these comments into consideration. So yes, point well taken. Any other comments? Yes, Dr. Shaw.
I see the word nursing care will not replace nursing care throughout. What do we define nursing care as in this context of this particular document? Are we talking about giving patient medication? Are we talking about inserting a Foley? Or are we talking about, turning the patient, or preventing falls? Because sometimes artificial intelligence can be a part of that process. And is that considered nursing care? So what do we define nursing care as in this statement?
So I think I'm looking at Stacy, and I think she'll be able to articulate this much better than I could, but it's all related to the components for practice. So for the RN and the LPN, that's what's going to drive that. So we're not going to drill down to those specific duties of a Foley insertion or medication administration. It's those components of practice that we're going to focus on. Stacy, did I do a good job? Wow.
Yeah, and I just asked, so coming from an employer perspective, when we read these statements, we look at them very differently than maybe somebody from the other side of education and maybe even as an individual nurse, right? So I think the points thanks for the clarification. I don't know if we need to expound on that or clarify that in here. I'm not sure because employers take terms very literally, and it becomes a full-time job trying to articulate what one word in an entire position statement means. So we might need to do some explanation, but I would just offer, just in reading this, I think it's a lot of information. And from an employer perspective, would prefer just get to the point and what are we really what is the purpose of this position statement, and maybe concise it or bring it down a little bit. It's just a lot of information. So the more words and the more information we have, the more we're going to read into it, and we're going to start critiquing every sentence and what that means. So I think I would recommend if we could, you know, outline it a little bit better and make it more palatable, where it's just simple, straight to the point. Because I think at this point, we still are learning what AI means and how to use it. And, I think organizations are still struggling with creating a policy. So if this is to challenge organizations about policies and different things like that, I think they're still figuring that out as well. So if we can just at minimum, really, what is the purpose of this? And so that it can be easily utilized in the setting from an employer perspective, and how we take these documents and use these documents in practice.
Thank you, Dr. Shaw.
Ma'am?
Yes.
So I appreciate that feedback. What I would say, and this is our new format for our position statements, that we're going to be moving forward slowly with changing all of our position statements to really narrow them down and make them shorter for that bedside nurse that's out there at 2:00 in the morning that's trying to read through a position statement to get some guidance to truly understand. So part of that process and thinking was throwing a question out there. What is the question that we are answering for nurses, employers of nurses? And so that is the very first question. And then if you flip over to the conclusion, you can skip. It's like the abstract and the conclusion. So read the abstract really quickly, and then you can get to the conclusion, and the conclusion should answer the question, right? And then there's some fluff in there, which, one consideration we could think about is removing a definition of AI. Do we need to define AI? And that can shorten the position statement as well. So we can work through that. But I think the sections in here go to the comments that were made throughout about the nurse's responsibility related to the utilization of AI, and gives them a little bit more information. Of course, if there's employers or other people or other individuals that have questions about the position statements, practice@ncbon.com, aprnpractice@ncbon.com. Reach out to us, ask us questions, putting a shameless plug in there for anybody that's still listening via our YouTube page. But that's why we're here, is to answer those questions for those individuals. And then if we find that we're receiving the same question over and over and over again, we can bring it back to the board and say, we've received this question 15 times or 30 times, whatever that number is, and can we amend the position statement to add or delete? So this gives us a jumping off point.
Yeah, and I always, as a practice leader, always appreciate the position statements, but also have to be the translator of them to the rest of the world, and that is an incredibly hard job. And sometimes we just have too much information in it. So I think if this is an opportunity, especially with this particular topic, to really just make it as meaningful for what we're trying to do. And I would say, when I hear about what people want to know, it's more around, what does it mean for their license? What are they accountable for in this process? Those are the things. It's not so much about what AI is and those types of things. It's like, what is going to happen to, is my license at jeopardy for XYZ? What am I accountable for in these AI workflows that I'm involved in, but not involved in, kind of thing. And so I feel like those are the things that bubble up all the time that I hear. But they're constant conversations that I think as leaders are trying to understand too, because it's new. I also think it's important to keep it simple, because there are healthcare systems that they're national. They cover multiple states, and so we don't want to pigeonhole ourselves into anything specific. I know North Carolina doesn't do that, but we don't want to get into that space of getting too prescriptive or introducing something to then it becomes what about everybody else, and they don't have anything. So that brings complexities as well. But I appreciate you listening to me. Thank you.
Thank you, Dr. Shaw. Any additional comments, suggestions? And so I believe we are going to take a break and allow staff to look over the position statement and consider those recommendations. And we'll come back, yeah, let's say 2:15. Thank you. The Education and Practice Committee meeting is now back in session. I am going to turn this over to Dr. Sarah Griffith and company team to present the changes to the draft position statement. Thank you.
Thank you, Madam Chair. So we all worked together to try to make all the edits that were suggested, including adding the bias towards the beginning of the paragraph. We changed nursing practice to critical thinking. Y'all are going to have to help me with some of these other edits that we've made.
We've removed.
We removed the definition that was in there. We felt like
definition.
that was no longer needed.
We removed some of the links for the MPA since the resources at the end of the document contain the links to the MPA.
We did remove a lot of words that were, or statements that were made over and over again, to help clean up some of the wording throughout the position statement. Reduce the length of the conclusion statement to make it a little bit clearer. Giving you all a chance to read.
I see hands are still down reading, and so we'll allow questions, comments, a little more time to read over the document for clarity. Can you turn your mic on, Dr. Shaw?
Yep, thank you. So in the first paragraph, the AI tools are being incorporated kind of third or fourth sentence down. This includes, this talked about privacy, security, transparency, accuracy, bias, blah, blah. Use of AI are essential considerations for safe practice. And this includes both data provided to AI tools and the output generated by AI tools. Is this just really a statement, or is this implying that the nurse is responsible for or has accountability in ensuring that the data that's provided to the AI tools, because they don't really have always control of that. That's not always something, you know what I'm saying? That's not something in practice that they will always have control over. So is this just a statement, or is this implying, to a responsibility or accountability by the nurse?
So it's both. It is what they are. So by including privacy, security, transparency, accuracy, bias, those are all things that they need to be aware of that's incorporated in the use of AI. And they need to be aware that what's put into AI and what's generated by AI, they are, if they're relying on it, they're accountable for it. So if they put in something to AI, they can't put PHI in an AI tool, right? Because that would be a violation of privacy. But no, it's always going to be a violation of privacy. But that is the issue, and they need to be aware that, not only are they responsible for relying on inaccurate information if something comes back, if they put something in there, they need to be aware that what they put in there might not be the best prompt for that situation. Ultimately, if they put something down that they've relied on for AI, they're responsible for it.
Yeah, and I think how I read this, I think it's both ways, but to me, it's saying that I guess what I'm trying to say, in the real world, they're not going to know what everything has been put into some sort of tool or platform. They're just not going to know that. That might come from another person. It may come from logic in the workflow of a particular software or platform that just happen to have, an embedded aspect of AI. So to me, it's like again, employers read into these things. So every clinician, nurse, doctor, they're not going to know what was everything that was put into these AI tools. It might not even be anything put into those AI tools. So just depends on where that support of AI is. So if I just feel like this sentence is it intended as just a statement, or is it intended also as you're responsible for knowing the data that's provided to the AI tools? And if that's the case, I just feel like that is too restrictive and prescriptive when it gets to the employer side, because a nurse, it may not know that information, and they probably shouldn't, because they don't know. Like, that's just not the logic of that particular AI tool. I just want to, that's from my perspective, and how I see AI. Yeah.
Madam Chair, I think we would not hold a nurse accountable for what an entire organization has deployed within the medical record. I think the intent of this portion is to let the nurse know information that they have input into an AI tool and information that's been generated from an AI tool that they use. They are responsible for that, to ensure that privacy, security, transparency, accuracy, to consider all of those elements. But this is not to mean that a nurse would be responsible for something that a physician may have input in 2 years ago into the medical record using AI, if that helps to clarify.
I mean, it does, but it doesn't to someone who hasn't heard this conversation. So again, I think where I get lean to that sentiment, because right after that sentence, you go into nurses should. So that's what's bringing me to think what's said before is their total responsibility. Yes, Stacy. Sorry.
I defer to you. Okay, yes.
So I hear what you're saying, except because that sentence does not call out the nurse's actions. You feel like it can be read to be generalized to what the organization has set up with the AI tool. Is that, it's not specified to the nurse's actions? Is that what you're
I think
reading
it
that
could
as?
be read as it's specified that the nurse has some accountability in ensuring that the data provided to AI tool.
So if that
Another
was.
way I can read that
Uh-huh.
sentence. I understand it's probably just general understanding that, information
What
is
if
put in
we
there.
designate that it's information, it includes data provided by the nurse to the AI tool and information generated by
the AI tool.
Do we need to say it at all? I'm just saying.
I do feel that that's kind of under the use, but that's an educated use policy. So do we need to be explicit or not explicit?
Okay.
I was just hearing your concerns and what Stacy said. I just was gonna say, what if you ended the sentence at nursing practice? Safe nursing practice.
Yes. I kind of honestly, I would just take that this includes both data provided to AI tools and output generated, blah, blah, blah. I would take that out and stop at nursing practice. To your point, I think it's implied, and it might even be somewhat implied down further somewhere.
Anything else, Dr. Shaw?
Yes, I'm sorry.
Okay.
And then nurses have a professional responsibility to be informed about the capabilities, limitations, and risks. So when we say to be informed about, is this intending for the nurse to then go to the organization and say, you must inform me? What does this sentence mean in the context of this document?
Yes, I'm sorry, I'm reading. Yes, Meredith.
Thank you. So as the Board of Nursing doesn't regulate employers or nursing employers, that is solely the responsibility of the nurse. So it doesn't speak to we can't speak to what the nursing employer has to do.
Yes.
But it may bring up conversations by that nurse to the employer saying, I'm reading this position statement and I need to understand AI more. You're implementing this on my unit. And I don't understand how AI is related to my nursing practice or how I can utilize this tool. So hopefully that will open up the conversation with the employer. We don't have any statutory authority over the employer and what they do. We do have that statutory authority over those licensed nurses. And so those licensed nurses are the ones that are to be going to the employers to ask those questions, to be the innovators that I think they are, right?
Yeah. And so I would say if that's the case, could we reword that just a little bit to basically say, nurses have the professional responsibility. It's almost like, work with your organization or employer, whatever, to understand those risks and capabilities and limitations. I think the word to be informed about, to me as an employer, it gives me the kind of the indication that there's a requirement for us to do that. We're mandated to do that. When I see the word informed, like to be informed about, that means somebody else needs to inform me. And yes, it's the employer, but it's almost like, is this a requirement, a regulation to us to do, the employer to do that? And we should, but again, I'm reading it from the perspective of how people interpret these words. So I don't know if we can just be a little bit, it's your responsibility as a nurse, which is, I think what you're saying, to understand the limitations and capabilities of AI tools. I mean, that's what you're trying to say. I think the to be informed about kind of gives me, again, thinking it's the mandate. We're mandating our organizations, employers to provide them with some specific information. I'm just reading it. That's how I'm interpreting it. I understand what we're trying to say.
Yes, Dr. Kistler?
So perhaps if you read that sentence and then you read under nurses have a professional responsibility to be informed about AI, it's redundant. And
Yeah.
I prefer the statement under the nurses' professional responsibility. I think that owns what the nurse can own, whereas the top one kind of lends itself within the environment of healthcare, whereas this one is more directed on, here's your responsibility as the nurse in your role. And it even says under the standards of practice. So if we want to reduce redundancy, we may be more clear in that second statement.
And I had that one underlined too, under there. I felt it was redundant of what was trying to say at the top.
Which statement are you referring to? The use of AI?
So
The
Dr.
last
Shaw's
sentence?
statement in the introductory paragraph
Yes.
is redundant where it says nurses have the professional responsibility to be informed about AI because AI generative information may be incomplete, inaccurate, or biased. They have a responsibility for accuracy, relevance, and appropriateness within their patient clinical situation. I feel like there's just redundancy, but I think it's worded a bit more clear in that statement.
It's kind of stated almost twice. So in the introductory, the first paragraph, like the sentence before the last, kind of almost is restated. If you go down towards the bottom header where it says nurse have a responsibility to be informed, there's a whole nother sentence that kind of says something very similar to that. And I think what Dr. Kistler is saying is probably that one down at the bottom is a little bit more, leans more on the nurse's professional responsibility versus having a perception that the organizations require, even though, that's their responsibility and they should and probably do, but just to clarify.
Thank you, Dr. Shaw. Anything else?
Then, let's see. The last one under nurses are accountable for their own practice. The last sentence says any information generated by AI must be reviewed and validated by the nurse before it is relied upon in practice. So is that any information generated by AI from the nurse? Because there's lots of stuff that is generated by AI, and I don't think we're trying to say that the nurse is responsible to review and validate every single thing that's generated. That's impossible. Thank you.
Thank you for that question. So the way I look at that statement is like the sepsis bundles that they talked about during the presentation. So if a patient comes in and they're not hitting all the indicators for a sepsis bundle and for the nurse to administer antibiotics or fluids or whatever is required of that order set, then that nurse should have that critical thinking ability to say, this isn't right for this patient because I'm not seeing what the AI generated sepsis bundle is telling me that I need to do for this patient. I'm not seeing this clinically in the patient. So they should raise that question to the provider. Does that make sense?
It does, but I don't know. I feel like there's a missing part to this because again, we're talking about AI. We're not being specific of what type of AI, what type of tool we're talking about. So that example that you use is a specific example, but that's not a general example, right? So there are many other examples of AI, and I don't think if you kept this line in here, it's not applicable to there's so much that's generated by AI. And when you say must be reviewed and validated by the nurse, that is where do we draw the line at? So again, is this necessary to even put that in here? Because at the end of the day, it's the nurse's responsibility to validate and review any information, regardless of if it's generated by AI. That's a part of our practice. So does that sentence even need to be in there?
Okay, thank you, Dr. Shaw. Yes, Angie.
I think that's a great point. I think if you back up a sentence or two, it says even when AI-enabled tools are used, nurses are accountable for their own practice, maintaining competence, et cetera. That sounds like if taking out that last sentence, any information generated is covered in that other sentence. So it might be redundant.
Thank you, and I rest my comments.
Thank you. Thank you.
Thank you, Dr. Shaw. Any additional comments? Feedback?
I'm just going to make a point of clarification. In the first version, where it says the AI tools are being incorporated into nursing practice, last paragraph. In the first one, it said current examples of AI use in nursing may include. I suspect the intent here is just to reduce language, but I think that may could be permissive and understood as you're allowed to do these things, but you're not allowed to do other things that are not listed here. That's why I like the term example in the last one, because it just was examples that may be used. And if nobody else feels that that's a clarifying permissive versus non-permissive, I'm okay with it, but that's kind of the language that I was hearing. The last sentence of that long section says AI use in nursing practice may include documentation support, development of patient care. In the previous version, it said current examples. And I just wonder if somebody may read that as these are permissive uses of versus non-permissive uses.
Would a clarifying statement of adding AI use in nursing practice, I don't have my wording right, but including, but is not limited to?
You could do that, or just say current examples. You could just add that for first two words back. The first one said current examples of AI use in nursing may include.
Yeah, you might want to add the limited, but not limited to.
I like that one.
Yeah, we were trying to stay away from current because we want this to be recognized again.
Additional comments? Questions? So my comment is really simple. Dr. Griffith, it was just the new document, AI tools are being incorporated into nursing practice. So that second line there, nursing care delivery, I think I showed it to you, but I just wanted to state it. We changed that under issue. We changed nursing care delivery to nursing practice. So do we need to change nursing care delivery here to nursing practice? And if there are no additional comments and questions, okay. All right, so if there's no further discussion in this matter, do I have a motion to approve the position statement recommendation with the recommendations for amendments for the use of artificial intelligence in nursing practice and directed to the full board in October? Okay, it has been moved by Dr. Kistler. Is there a second? Seconded by Dr. Moore. All in favor by show of hands, and that is a unanimous vote by the committee. Congratulations. And so as there is no further business for this committee to address today, I need a motion and a second to adjourn the meeting. Okay, Dr. Kistler has moved to adjourn, seconded by Andrea Jepson. All in favor by show of hands, and that's a unanimous vote as well. This meeting is adjourned. Thank you.
So we'll clean that up. Okay, and you all will have another chance to.